Join the Library of Virginia in celebrating its 200th anniversary as the state's oldest agency dedicated to preserving Virginia's history and culture. 200 years, 200 stories, a free exhibition and multimedia experience celebrates 200 Virginians whose fascinating narratives are housed in the library's vast collections. From the unknown to the known, from the powerful to the powerless. Start here to find the stories of Virginia. Visit lva.virginia.gov to learn about anniversary events.
The other thing, and I think do you have any data back before? Well, I'm sure there's something that's going to be alive and.
I've seen it repeatedly, just
Especially if anyone yes, I think that's right. One more thing.
Tyler focuses on relationships, transparency, and data to assess critical needs and provide solutions statewide. Learn how Virginians can create a connected community with Tyler's data and analytics solutions. Tyler focuses on relationships, transparency, and data to assess critical needs and provide solutions statewide. Learn how Virginians can create a connected community with Tyler's data and analytics solutions. Join the Library of Virginia in celebrating its 200th anniversary as the state's oldest agency dedicated to preserving Virginia's history and culture. 200 years, 200 stories, a free exhibition and multimedia experience celebrates 200 Virginians whose fascinating narratives are housed in the library's vast collections. From the unknown to the known, from the powerful to the powerless. Start here to find the stories of Virginia. Visit lva.virginia.gov to learn about anniversary events. When you want to make sense of a complicated world, start here at the Library of Virginia, the world's most comprehensive resource for exploring Virginia's government, history, and culture. Learn more at lva.virginia.gov. Tyler focuses on relationships, transparency, and data to assess critical needs and provide solutions statewide. Learn how Virginians can create a connected community with Tyler's data and analytics solutions. Join the Library of Virginia in celebrating its 200th anniversary as the state's oldest agency dedicated to preserving Virginia's history and culture. 200 years, 200 stories, a free exhibition and multimedia experience. Celebrates 200 Virginians whose fascinating narratives are housed in the library's vast collections, from the unknown to the known, from the powerful to the powerless. Start here to find the stories of Virginia. Visit lva.virginia.gov to learn about anniversary events.
I don't feel bad at all.
What you were looking for.
Should be able.
Yeah, I know, it really is. You're so right about that. So
Gus, good morning. We're going to go ahead and get started here in about 30 seconds. So if you all want to take your seats, grab a last cup of coffee. We'll get started here in 1 minute.
What's the chance?
Good morning. Probably one more time. Good morning. It is an amazing day to be here in the Commonwealth of Virginia. My name is Alex Vanessian, and I'm going to step back from the microphone. I'll just talk softer. My name is Alex D. Can y'all still hear me good? Welcome to Virginia Datathon 2023. This is our 9th year doing the Datathon, and I am super excited to be here with you all today. It is. Okay. There you go. Good. Can everybody hear me in the back of the room? Great. For those of you joining from Zoom, I hope you can still hear. If not, let us know. We're good there too. Well, thank you. Much better. Is that okay? Great. Welcome to Virginia Datathon 2023. My name is Alex D. I'm with GCOM, and we are super excited to be here today. This is year number 9 for the Datathon, and every year it gets better and better. I won't take much time this morning to do just some general discussion. We have a long list of items to get through today, and the best part of today is hearing from the teams presenting. So today we have 16 teams representing K-12, higher ed, public sector, private sector from around the Commonwealth that have come together to help solve problems. And I can't say thank you enough to all the teams that have been working over the last week to come up with solutions to some of our most challenging problems we have and opportunities we have in the Commonwealth. I will save some remarks for later, but I actually have the absolute amazing opportunity to introduce Dr. Sandra Treadway. Dr. Treadway has been the librarian of Virginia for here, the Library of Virginia, since 2007. We are super fortunate to have Dr. Treadway, not just in Richmond, not just in the Commonwealth, but truly a leader around the country as we look at libraries and archives and collections. Dr. Treadway is a leader in this space, has led this library through multiple transformations in her time here, and is part of an amazing celebration this year of 200 years. Dr. Treadway has not been here for 200 years. I want to make sure that is not in the script, but she has been part of some amazing transformations, and she and her team at the Library of Virginia deserve some huge kudos for all of that. So please join me in a round of applause. Dr. Treadway is a graduate of Manhattanville College and holds a doctoral degree in American history from the University of Virginia and a master's degree in library information sciences from the University of Tennessee. She's an author. She's engaged here in the community. She serves on several commissions and state boards. And again, as I mentioned, I can't tell you how proud I am of Dr. Treadway and of all the work she has done. For those, how many people is this the first time they've been to the Library of Virginia? All right. Well, if this is the first time, please come back. The library has some amazing programming that truly impact us all. Their archives and collections are unmatched. As I mentioned earlier, their on-site and off-site locations have items that are truly one of a kind in this country and in the world. And it's my honor and pleasure to introduce a true partner in this, Dr. Treadway.
Thank you, Alex. Alex is most generous and most kind, but we could not do this without him, and we're so grateful that he comes back every year. So good morning and welcome to the Library of Virginia and to the final day of the 2023 Virginia Datathon. As Alex mentioned, I'm Sandy Treadway, the librarian of Virginia, and I am very excited that the library is hosting today's presentations by all the intrepid teams who've been working hard this week, mining publicly available data to develop innovative solutions to one of our country's most important public health challenges, and that of maternal mortality. The library is very proud to partner with the Commonwealth's Office of Data Governance and Analytics to produce this year's Datathon, as we have in the past several years. Making data available and promoting its use to serve the public good is one of the most important things the Office of Data Analytics and Governance and Analytics does. And the Datathon is a wonderful way to show how impactful this work can be. The Library of Virginia is the most appropriate partner in the Datathon, since as a library, we are all about open data. In fact, I like to think of us as the first open data portal in the state. We were founded in 1823 for the purpose of organizing and the vast amount of information that Virginia had been collecting and generating since the earliest days of settlement at Jamestown, and making that accessible to all those who needed to use it. We are the research and reference library at the seat of government, and this building houses some of the Commonwealth's oldest and most precious documents. So think draft of Virginia's Declaration of Rights in 1776 with George Mason's editorial comments on the draft. The Statute of Religious Freedom that was inspired by Thomas Jefferson, and all of Virginia's constitutions since 1776. And that's just to mention a few really critical pieces. But we also have millions of public records and private documents that record the experiences of ordinary Virginians who never became famous, men and women of all backgrounds whose life stories make up the fabric of our Commonwealth. Here too, you will find some of the most modern information resources available anywhere. So whether you're researching Virginia history or your own family story, or you want to know more about the evolution of government, this is the place you come and the place to start. And you can find us online too, because for the past 30 years, as Alex alluded to, we have been employing technology to share our collections far and wide. We are a leader among state archives in digitization of historical materials. And today we invite the public to help us transcribe many of those digital documents that are online so that others may use them more easily. So a moment ago, I mentioned we were founded in 1823. So if you did the math, you know this is, and as Alex said, our 200th anniversary. And we have many exciting programs happening here at the library. And to highlight various episodes in that history. And one of them is located to the rear of the lobby. It's a special exhibition called 200 Years and 200 Stories. So I hope you'll take a moment at lunch or when you have a break to walk through that and pull open the drawers and some of the cabinets to see just a little smidgen of the items that we have in the collection. We've also initiated an outreach effort, and we will be visiting communities across Virginia in a special vehicle that our foundation paid for to acquaint Virginians with what we do, why it matters to them, and how we can help them. Now, in closing, I would like to thank all of you who have made today possible. I especially want to recognize all the sponsors. Again, we couldn't have some of the food, the t-shirts, and some of the amenities that we are able to offer our teams without you. And I very much want to thank our amazing IT team here at the Library of Virginia, especially our director, Paul Casalaspi, and our desktop and applications guru, Mike Ezapek. They have gone above and beyond to make this wonderful event possible, and it would not happen without them. And now it is my great pleasure to introduce Virginia's Deputy Secretary of Health and Human Resources, Leah Mills. Prior to joining Governor Youngkin's administration, Deputy Secretary Mills worked at the Virginia Department for Aging and Rehabilitative Services, where she supported policies to promote the independence, inclusion, and employment of all Virginians. Previously, she worked as a senior legislative analyst at the Virginia General Assembly's Commission on Youth, which is tasked with studying and providing bipartisan solutions on a variety of issues impacting young Virginians and their families. She has fulfilled several roles with the Virginia Department of Medical Assistance Services and served on a variety of task forces to address youth and family issues. Please join me in welcoming Deputy Secretary of Health and Human Resources, Leah Mills.
Good morning, everyone. Can you all hear me in the back okay? Okay, great. Okay. Thank you so much for having me here today. I am just so humbled to be here. I can honestly say that I feel like, and I know that I am the least smart person in the room right now, truly, with you all being here. And I'm so looking forward to see and hear all that about your projects today. I want to thank you all for your commitment and your time and helping us tackle one of the most important issues, maternal mortality. Governor Youngkin and my Secretary John Littell are very, very committed to tackling this issue. As you all probably know better than I do, because I know you've been looking at the data points, maternal mortality has really been an issue in the Commonwealth. And between 2016 and 2020, maternal mortality has been 21.6 out of 100,000 live births in the Commonwealth. And it's even more so for women of color. And we need to do a better job and tackling this issue. And we know that data and data-driven policy initiatives are what we need to help us solve these issues. So I wanted to talk to you about that today. But before I do that, first, I want to thank the Library of Virginia for hosting this wonderful event. And I want to thank the sponsors for all that they do. And again, thank you all for your time and energies with helping us and our secretariat with this issue, and it's very critically important. So what I thought I would do first is maybe give you a quick thumbnail sketch about our secretariat and some of the agencies and our issues. And then I thought it might be helpful for you to give you kind of like a real life case study about what we're doing in our secretariat now. And because it has a maternal and infant health initiative with it. And I thought you might be interested in how we use data to inform our decisions. And finally, I thought what I would do is tell you about a couple other select maternal and infant health initiatives in the Commonwealth that some of our agencies are tackling, just to give you some real world examples, if you will, because all of them really are so reliant upon the data. So let me get started with an overview about our secretariat, just to give you all an idea about the depth and breadth about some of our programs. So our secretariat accounts for 1/3 of the budget in the Commonwealth of Virginia, which about $28 billion, if you can believe it. And it's has 12 agencies that have a range of programs and initiatives. So as Dr. Treadway had said very graciously, I have the good distinction and honor of serving my time in 2 of those agencies. One of them I'm going to tell you more about now in a little bit is the Department of Medical Assistance Services, which has a lot to do with maternal mortality. And we're going to be working with them very closely in the years to come with tackling some of these issues. And maybe some of you all have looked at some of their data, and also the Virginia Department of Health. So those are 2 of the agencies that are underneath our secretariat. And you all probably know a lot about, particularly the Virginia Department of Health, because of the work that they did during the COVID pandemic. They have 35 health districts, 118 health departments all across the Commonwealth, provide a variety of services across the Commonwealth. And I think they touch every Virginian from birth to death, because they handle vital records, they handle death certificates, they handle water sewer permits, and of course, COVID pandemic. We have our Department of Medical Assistance Services, which is Medicaid. And do you know that they account for 1 out of every 3 live births in the Commonwealth, which is amazing when you stop to think about it. And then we have our other agencies. We have our Department of Social Services that provides benefits, adult protective services, child protective services, child welfare benefits. I'm sure I'm leaving something out. And then our disability agencies, Department of Aging and Rehabilitative Services, that we have workforce programs in that agency, and they administer our Older American Act funds for aging services for vulnerable adults. And then we have an array of disability agencies that provide services too. So just a lot of programs and initiatives underneath our secretariat. I will tell you, never a dull moment, but so just quite something to keep us hopping all the time. But I thought it would be interesting to tell you all a little bit again about our partnership for Petersburg, which the governor launched back in August, because as I mentioned, it does have an initiative that pertains to maternal and infant health. And I thought that might be informative and interesting to you all with your, just to give you kind of a thumbnail sketch about what we're doing with that and highlight again, the need for data-driven decisions, which is something Governor Youngkin is committed to with all state government to make sure that Virginia is the best place to live, work, and raise a family. So the Partnership for Petersburg was launched by Governor Youngkin in August of 2022 in response to pervasive negative outcomes experienced by Petersburg residents. And just quickly, it's not just Health and Human Resources that has partnered with the city. It's 6 pillars. It is public safety, education, agriculture, transportation, and commerce and trade. So I'm just going to highlight our partnership on the Health and Human Resources front. What happened back in February of 2022, the governor and my Secretary Littell, was traveling the state, doing a lot of work to combat vaccine hesitancy, came to Petersburg, fell in love with the city, has so many beautiful assets. It's a very historic place, but found that Petersburg pretty much ranks last across the Commonwealth for everything, which I will show you with Health and Human Resources data here right now. And I know this data is a little bit small, so let me go ahead and see what I can read for you here. So based on the county health rankings put out by the University of Wisconsin, citizens of Petersburg live about 13 years less than the average Virginian. Petersburg ranks, as an aside, last for pretty much every health metric in Virginia, other than accessibility to outside space for exercise, and they're about above the median for access to healthcare providers, which I'll show you in a minute. The chart on your right is key health indicators. Child mortality is 180% higher than the state average. Infant mortality is 83% higher. Teen births are 333% higher, which is astonishing than the statewide average. As an aside, at the same time that we were gathering this data, we were looking at the services in the community. The Crater Health District only offers a teen health clinic on Thursdays from 1 to 5. It's not very helpful to have a teen health clinic for pregnancy prevention or pregnancy services when high school kids are in school. So that is one example about maybe we need to rethink how we're offering our services. Providers. So the bar graph on the left is access to primary care physicians. The blue, again, is Petersburg, slightly above the state average. Mental health providers, orange is Petersburg. Yeah. So you can see, blue is Petersburg. Mental health providers, Petersburg is actually doing rather well. The thought is Central State Hospital is nearby, so that might be skewing the results. But all in all, the number of dentists, Petersburg actually has pretty good access to dentists. They're not as bad off with their number of providers access as a lot of regions across the Commonwealth. Social determinants of health measures. The number of children in poverty is 200% higher than the state average. Unemployment is 120% higher. Single children in single parent households, 110% higher. Food insecurity is 77% higher, and limited access to healthy foods is 575% higher. So we have been doing this. There's a study that has been conducted with our Virginia Department of Health on the last metric with the 575% higher with access to healthy foods, that pregnant moms that don't have access to healthy food have a higher chance of mortality, which maybe you all have seen that data point too. Let me give you some statistics about Medicaid eligibility in Petersburg. Approximately at the time that this data was gathered last year, 60% of the residents in the city had Medicaid, 19,000. Probably about 95%, I didn't do the math, but the majority are enrolled in managed care. And there are 6 managed care organizations that participate, that are Medicaid, that are participating in Medicaid. I'm not saying that properly. Katie will have to correct me over here, but there's 6 managed care organizations in Medicaid that provide services to our enrollees. And what that means is that the city residents have access to case management. And then there are some other data points too. There's over 7,000 children that are enrolled in Medicaid. The last bullet, there are 280 women that have Medicaid eligibility that were pregnant at the time that this data point was pulled. So it ranges anywhere between like about 200 to 300 like point in time data in the city of Petersburg. And this just happened to be 280 in January. So this is important because women that have Medicaid eligible, that are enrolled in Medicaid due to being pregnant, stay on Medicaid 12 months postpartum. So we have, with our Partnership for Petersburg and our secretariat, we have 11 initiatives, 4 that we call our day 1, and then 7 that are more day 2 that are related to social determinants of health and maybe workforce employment. And so the ones I'm going to talk about today are really related to our Department of Medical Assistance Services, and they've just been outstanding partners with the city and Director Cheryl Roberts and her team with helping to see how we can move the needle on maternal and infant health outcomes. So, and using, again, the data that they collect with helping inform their efforts, okay? So these are our day 1 initiatives. These are the 2 I was going to share with you all today. And Governor Youngkin was very, very excited because when he saw the data points that we shared with him, he had said to our secretary, we have got to do something. And so what we felt that we could do at the state level is we needed to improve Petersburg maternal and infant health outcomes. And we needed to, what we could also do is using the 6 managed care organizations, we could provide mobile healthcare clinics because the managed care organizations have access to those in the community at community events, get out in the community where the residents are for health screenings and services. So those are the 2 that were we did with our Department of Medical Assistance Services. So this top bullet point pertaining to prenatal and postpartum care, when our DMAS folks pulled the data for us, when they looked at their data, they found, and they had to go back and state fiscal year 2021 and it wasn't the 280 I cited to, it was more like, I think at the point in time data, it was approximately like 100 plus, they did the point in time data. Only 20% of those pregnant women received prenatal care, which is alarming. This was back when they pulled that data. So I think you all know that just is so indicative of could be horrible outcomes. So in response, what the Department of Medical Assistance did under the leadership of their director and their team is they thought, what can we do? So just an example of data-driven decision policy making is they decided that they would write, because they had access to the information of who was pregnant, they would conduct a letter writing campaign, but not just a letter writing campaign. They sent handwritten notes to these, it's under about 100 women that were pregnant at that point in time, because nobody would typically toss like a handwritten note in the trash. We all are guilty, I'm sure, of tossing our form letters in the trash, and put information about where the pregnant moms could access care. So this is the flyer that they would be eligible for 12 months of care postpartum, how to get services, the phone number, the website, all the access that they had, including dental care, and put it in like a nice note, almost to make it look like an invitation, like a party invitation. And so they are following up on that. They did the first follow-up back in the fall. And so they found that 76% of the members that they did that with reached out and scheduled a prenatal visit. And so the metric that they are using is if they could just get their members to have one prenatal visit, just one. And then we're trying to see about getting them, and Katie probably knows about this, one postpartum visit, because at least one, because now it's none. And then our managed care organizations are working to build the doula network, serving Petersburg and connecting with interested Petersburg members. So doulas are a provider, and maybe you all have looked at that model in your research, that provide wraparound services to our members. And they are, if they enroll with a managed care organization, it's a covered Medicaid service. They will cover 4 prenatal visits, 4 postpartum visits, and they're trained non-medical professionals, and they provide continuous physical, emotional, and informational support, including childbirth education, lactation support to pregnant moms throughout pregnancy and labor. So they have that community link. They're also approximately 25 in the area. So they're like that community voice, that community messenger, if you will, that trusted voice in the community. So the managed care organizations have been working to make sure that the Virginia Department of Health certifies the doulas. And then if they are enrolled in managed care, they can go out and maybe conduct outreach with our Medicaid eligible recipients in Petersburg. So stay tuned. We're still working with that initiative, but just an example about how we're using the data to inform us with our Petersburg initiative. Just some other highlights related to our social determinants of health and what our managed care organizations have done. They have not unlike some of the sponsors today, that have been such great partners. They have foundations that have contributed. And so they have hosted community events, other mobile clinics. They donated, toothbrushes, crevettes, books, charitable contributions, just been amazing partners. Another quick story, they were going to an event and found that a little boy handed a toothbrush. He was so excited, and he said he didn't have to share with his brothers anymore. Can you imagine? So the managed care organizations now have been donating toothbrushes on a quarterly basis to all the schools, not with any kind of state funding, but just with their foundation funding, because dental care is linked to so many other critical health issues, as you all probably know. So just a great partnership. Okay, and that's our Director Roberts and her team that have been out there. So we have been working with our maternal and infant health collaboration about how we can do better. And these are the providers in the area listed on the left that, as I said, that we have, we do have some good providers and partners, and they're committed to working with the citizens and the residents in Petersburg to try to improve access to prenatal and postpartum care for moms and their babies. The last bullet is Urban Baby Beginnings. We had an exciting ribbon cutting last week. They're a community maternal hub, which I'll tell you about here in a minute. But some of the things that we've been working with our partners is access. Are moms working? Do they need additional access after hours? Do they need maybe a once a month Saturday clinic? So we've been meeting with Director Roberts' leadership, trying to see, can we make that happen with some of these providers to improve access to care? Again, based on the data that they were good enough to pull for us. Okay, so these are the next steps. I think I kind of went through these. Working to expand maternity clinic hours to 1 weekend a month, the reporting on the progress on some of the things that the team has been doing with their note taking, expanding service. Oh, school-based. We have a school-based clinic at the Petersburg High School. And can we use them to augment the services at the health department clinic that is only the Thursday 1 to 5 to see about meeting the students where they are, and also expanding it because can they serve the community as well? Hopewell City does that. Can we do that also with Petersburg? So we're having conversations about with Petersburg. Can they expand their hours? Can they expand? Can they also see members of the student's family? Having more of an ongoing presence. And then we're going to go more to our day 2 social determinants of health soon. Okay. Urban Baby Beginnings is a maternal hub, which I told you the governor came to Petersburg and did a ribbon cutting. It was an excellent public partnership. Anthem, one of the managed care organizations, donated like over $800,000 to open this hub. And these are some of the services that are available. Wraparound support services to the community. No one is turned away. It's an open door access policy. It opens doula support, pregnancy navigation and care coordination by perinatal specialists, has the doula model, and it also supports doulas as well as moms and families. They have like a diaper pantry, they have formula, again, open access whenever, whatever moms need, it doesn't matter, no questions asked, just they can come, offer support to community-based lay workers, and it also is integrating telehealth social support. And this is one of 4 across the Commonwealth. And I just thought I'd show you a picture. It's a beautiful space. So moms feel supported, providers feel supported. And so the providers in the community refer moms and refer individuals there. And lastly, I know that's really little, I'm sorry about that. Our Virginia Department of Health is spearheading a vast array of other maternal and infant health initiatives. They oversee our Title V maternal and child block grant funds. So they have, through their departments, Virginia Department of local departments have their WIC specialists, which is critically important to, supporting child nutrition. The state doula certification program, I think I referenced that, making sure that non-medical professionals are certified and educated appropriately. Over 107 doulas to date have been certified. And then we have, I think, close to 60 that are eligible for Medicaid reimbursement. Pregnancy loss initiative, Virginia Department of Health is the only state health department that offers that to moms, that's supporting those individuals. They have a perinatal cannabis work group. This is educating providers about and lactating individuals about the harms of perinatal cannabis use. The neonatal perinatal collaborative. This is something that we partner with all the hospital systems, and the perinatal data and quality measures task force. So this is something that was established by our General Assembly, and this is going to help us better get a handle on data. And it's a legislative executive branch partnership, and we'll be reporting on that come December. So I hope I didn't exceed my time. Finally, I just want to again reiterate how grateful we are and hope that you all, when you all graduate, consider a career in public health, because we could certainly use your talents. We have plenty of opportunities in all of our agencies across the Commonwealth. We are very excited to see all the wonderful data and projects you have, and thank you again for your time and commitment. Okay.
Thank you, Deputy Secretary Mills. And again, just to reinforce the data that was shown and the data that was presented today, I mean, is life-changing for all of us, right? I mean, it's a very real view of what's happening today, and an opportunity and a thank you for me, for all of you, of not just talking about the item, but actually making time to help solve that problem as well. So Deputy Secretary Mills, thank you so much. In a small connection as well, I'll one aside to her Petersburg discussion, another great application of data. As part of that Petersburg project, there was a large, a higher volume of EMS or ambulance calls in certain areas. So we did a geospatial plot of ambulance calls in Petersburg and found different areas had higher concentrations of ambulance calls, right? There were heat maps that could very easily see that were not related to condition, codes in the ambulance, et cetera. And again, using data and working across multiple systems, we found that it wasn't the ambulance that was the item. It was bus stops and transportation that were the item. So they didn't have transportation to get to their doctor. So there's actually a discussion now of putting bus stops to get transportation to individuals so they don't rely on EMS to do their basic transportation needs, but to actually use the facilities and have facilities available to them to get them from there to their primary care or medical facility. So again, another great Petersburg example of data being used across the multiple silos and solving problems that are faced by all of our individuals today. All right, so we're going to actually move into a couple of the presentations. Let me actually go over the little bit of logistics today. Can you all still hear me in the back? Yes, great. All right, good. So today's going to be, again, presentations from 16 teams. We're going to have a break in the middle. So we'll do about 8 teams. We'll take a break, get a breather, give the judges a breather as well a little bit. As we have your teams come up, we'll do them in numerical order. We would actually like for those that are here in person to introduce yourselves, come up to the mic, introduce yourselves or your team. For those that are virtual, we can do that also virtually through the Zoom as well. Let me actually move this back. Mike, we good? Okay. So before we start, though, I do want to say a couple quick things. Again, a huge thank you to our partners, the Library of Virginia, which I mentioned earlier, and I think Ken just walked out, but to the ODGA, the Office of Data Governance and Analytics, they've been partners in this. Ken had just walked out, and I know Marcus is in the back. Marcus, Deputy Chief Data Officer for the Virginia. So thank you. And to the entire are people from the ODGA, are people in the room from ODGA, or are they out in the back? If you want to take a quick, if y'all can stand up really quickly, our team from ODGA, give them a quick round of hands. And Dr. Treadway mentioned the Library of Virginia staff. I know they're everywhere around us here. So again, a huge thank you to the Library of Virginia and their staff as well. Also a thank you to our sponsors. They're here on the screen: GCOM, Tower Technologies, Microsoft, Vertica, and Dataversity. We could not have done this without all of their partnership. Their booths are out and outside. Please take a moment to stop by some of their booths, introduce yourself. Each of those individuals is working on some very critical data things in the Commonwealth today. It'd be great to connect and use this opportunity to build your network in the data space as well. All right. We are now going to move into the presentation portion of our event. I do want to look at that. Nice. I like that. Good. The time y'all been waiting for. Let me do a quick introduction though of judges. We'll go into their bios a little bit later, but I do want to make sure you all recognize who your judges are and where they are. So they will be seated to your right, actually to your left currently, but when you're presenting to your right, Thank you, Dr. Barbara Burkett. She's with the Virginia Department of Aging and Rehabilitative Services, also a consultant epidemiologist with Virginia Department of Health. Thank you, Dr. Burkett, for all of your time here today. We'll do full intros in later before the awards. Katie Linkenauger is ELT Senior Advisor in Healthcare Analytics and Transformation for the Virginia Department of Medical Assistant Services. Thank you so much. And Logan Fink, Lead Scientist at the Division of Consolidated Laboratory Services. Logan has made multiple trips here today. So Logan, thank you for your time today and your round trip back and forth today as well. All right, let me pause. Let me actually, oh, good. Give your judges a round of applause. Very good. All right, are there any general questions before we begin presentations? Anyone have any questions, comments? All right. Wonderful. Isn't that real time? You like that? The real time data exchange right there. All right, so we are going to start with team number 1 from Deep Run High School, Data Dragons. If you are, I know you are here. Why don't you come up to the podium, introduce yourselves, and then Mike will launch your presentation. Data Dragons from Deep Run High School.
Hello, my name is Drew Malajker. I'm Abi Soma, and the rest of our team is not here today. But we are the Data Dragons from Deep Run High School, and we're excited to be here. This is personally our first time being in the Datathon, but this may be actually Deep Run's 3rd time being in the Datathon. And we're excited to try and win, and we're excited to meet all of you guys. So thank you for this opportunity.
Welcome. Today we'll be addressing the problem of maternal mortality.
I'm Abi.
I'm Drew.
I'm Taishi.
I'm Nico.
And I'm Nathan.
So first off, why are we talking about maternal mortality? Well, maternal mortality is something that affects families throughout Virginia. First off, 20.6% of mothers don't have access to high-quality prenatal care. This leads to inadequate treatment for both the mother and the child, which could not only cause the child to be born with unwanted symptoms, but it could lead to the death of the mother. Furthermore, this unavailability of prenatal care could also lead to unhealthy eating habits, which could result in obesity. 20.95% of mothers are obese. Although these numbers may seem small, keep in mind they can quickly add up when applied to a larger scale. Every mother deserves better and shouldn't have to sacrifice themselves during birth.
Our solution is Maternal Health Matters, a website that every woman in Virginia can access. There are many different parts of the website that will help women and their pregnancies, such as the anonymous form, the educational materials, nutritional quiz, and informational newsletter.
According to March of the Dimes, a respected nonprofit organization that works to improve the health of mothers and their children, a significant proportion of mothers do not. A major part of this website is the creation of an anonymous forum or messaging board consisting of multiple healthcare professionals. The goal of this board is to connect early or soon-to-be mothers with maternal health experts who can provide helpful facts and advice for those willing to anonymously voice their questions or concerns. This would not only provide these women with helpful information pertaining to their health, but emotional support, essential in the process of childbearing. More than 1 out of 4 mothers 34 and up do not have these important conversations regarding their mental health. Our safe and open online forum will help to remedy that.
Another part of our solution is providing a wide range of resources in order to improve maternal health rates. The goal of this portion is to provide step-by-step ways to increase awareness, improve nutrition, and provide social support. We ensured that these resources are visually appealing and accessible through our platform, Maternal Health Matters, to allow for them to be distributed and ultimately raise awareness about this issue. As seen in the graph on the right, the number of health discussions before pregnancy is below 70% for all age groups. This indicates that there is a negative stigma around this issue. This aspect of the solution specifically seeks to mitigate this risk factor to ultimately reduce maternal mortality.
At the same time, we need a nutritional quiz to best inform women about to enter a pregnancy. A medical quiz would best analyze current dietary habits, promote healthier diet options, and recommend sufficient nutrition. This would greatly reduce maternal mortality rates and promote the health of the mother by reversing unhealthy trends such as obesity, for which nearly 33.3% of childbearing women in Virginia faced in 2019.
The final part of our solution is an informational newsletter. Through our research, we discovered that anxiety around maternal mortality is abnormally high. The informational newsletter serves as a tool to provide information regarding this issue easily and accessibly. This part of the solution is composed of a team of experts in the field that provides nutrition tips, current healthcare news, and resources for community support. According to the graph on the right, 76% receive parental care, which this aspect of the solution seeks to improve to ultimately improve maternal mortality rate.
Yet, our solution also has some limitations. The main issue is that there's a limit on the reach that our website can cover. It cannot be accessed without the internet, which 5% of Virginians do not have. On the other hand, our solution has a wide range of implications, such as overall improved maternal health and an increased awareness for the tragedy that is maternal mortality.
So in conclusion,
in light of the lack of communication,
scarcity of social support,
and an insufficient understanding of maternal mortality,
our solution, an interactive user interface, would be best for Virginia and best for mothers. Thank you.
Thank you, Data Dragons and Deep Run High School, for kicking us off this year. A great way to start. A couple key things. So while there is judging going on at the front of the room, each of you will also have an opportunity to judge as well. So there will be a People's Choice Award this year. So please, wow, People's Choice. Hey. So keep jot down your team number, team name of the choice of the team you like the best. We'll have a People's Choice voting for everybody as well. Also online as well. You can do this online, but we'll have that at the end as well. So please, as you're listening to these, pick your People's Choice or pick your own individual choice for best presentation as well. And your input will go towards a prize as well. All right, let me do a quick sound check. Back in the room, I know it sounded fine here. Was that volume okay for the presentation? Wonderful. All right, our next group is going to be virtual, I believe. William and Mary Booz Allen Hamilton's The Number Ninjas. I believe they are virtual. So if you are on from The Number Ninjas, anyone on to introduce yourself? And if not, we will jump into your presentation. You can unmute yourself if you do. 5 more seconds. Mike, our next team is team number 2 from William Mary Booz Allen Hamilton, The Number Ninjas.
Hello everyone, and welcome to our presentation on combating maternal mortality. We are Team 2, The Number Ninjas. I'm glad you could join us today. The problem. Maternal mortality rates in the United States have exhibited an upward trend since 2000. The United States has a higher maternal mortality rate compared to other wealthy nations, which indicates the potential gaps in healthcare practices and accessibility. Virginia in particular ranks 18th out of 50 states in maternal mortality rate, which suggests there's room for improvement, and there's a need to address this issue for the Commonwealth. And maybe what's most concerning of all is that a significant proportion of maternal mortality cases are preventable with proper interventions and care. Our group has decided that our recommendation would be to encourage Virginia to participate in the Interstate Medical Licensure Compact, IMLC. This would enhance the recruitment and retention of physicians within the Commonwealth, thereby expanding access to skilled and affordable healthcare providers. Enhancing healthcare access can possibly reduce maternal mortality rates, which is why it's so important to implement solutions like the IMLC. In rural regions in particular, there's often a shortage of experienced physicians. Expanding telehealth services can help bridge this gap and increase the availability of qualified healthcare professionals in these areas. Therefore, by joining the IMLC, Virginia can attract and retain a larger pool of physicians, ultimately improving access to high-quality medical care for all of its residents, including expectant mothers. Now we will dive into our process and give some insight on how we came to our recommendation. Here we completed a correlation coefficient matrix for selected variables from the Health Opportunity Index dataset, including access to care, affordability, and other categories. Using this, we visualized a heat map of the correlation matrix, looking for potential relationships and patterns among the selected variables. And one key area to hone in on is access to care and wellness disparity profile, being 0.71. Next in our process, we performed a principal component analysis on the dataset to reduce dimensionality and identify other underlying patterns or structures. We created and analyzed the scatter plot on the right to explore potential trends, clusters, or patterns in the principal component space and relate these back to the original variables. We found that the reduced dimensional representation using PC1 and PC2 captures approximately half of the information from the original data. The Health Opportunity Index has a significant inverse relationship with PC1, while employment accessibility has a positive relationship with PC2. And finally, we created a scatter plot with k-means clustering to examine the relationship between income inequality and Health Opportunity Index, identifying potential groupings within this data. As you can see, there's an upward trend. As Health Opportunity Index is greater, so is income inequality. Now, our value proposition. Address maternal mortality rates in Virginia by leveraging data-driven insights, enhancing healthcare access, and providing targeted interventions in high-risk areas. Increase the availability of qualified healthcare professionals in rural areas by promoting telehealth initiatives, thereby improving healthcare accessibility for expectant mothers. Joining the IMLC to attract and retain skilled medical professionals, contributing to better healthcare access and improved maternal health outcomes. Prioritize the implementation of preventable measures and evidence-based practices to reduce the occurrence of avoidable maternal mortality cases. Finally, what value does this bring to the community and the Commonwealth? As for the IMLC, facilitates the movement of healthcare professionals across state borders, expands the availability of medical services for residents, simplifies access to medical attention in impoverished and underserved areas. It also helps to streamline the licensing procedure, leading to cost savings and reducing administrative burdens for physicians and state licensing boards. As for telehealth, telehealth broadens the availability of qualified medical professionals and helps to facilitate easier access to physicians for treatable conditions that could contribute to maternal mortality.
Again, as a reminder, that was Team 2, the Number Ninjas from William Mary and Booz Allen Hamilton. Next up, we have team number 4 from William and Mary, Crown Jewels, and I believe they are here. If you want to come up and introduce yourselves. Have a whole state.
We only heard the few.
Hello, 2023 Datathon. Are we awake? All right, we are the Crown Jewels. We're from William and Mary. My name is Sandra Sponseller.
Becky McDonald.
Diana Garcia, Mita Tapase.
And we have one more member, Dan, who is not here today. We're very excited to show you guys our presentation. Thank you. Dan, can you wait?
My wife was pregnant with her first child. She had a high-risk pregnancy due to placenta previa that required biweekly doctor's visits, medication, bed rest, and almost a dozen ultrasounds. If we did not have access to the high level of care provided by the University of Michigan health system, great insurance that covered most costs, and enough financial stability to pay for our portion of the care, this very well could have been fatal for my wife and daughter had it been left undiagnosed. Welcome to the maternal mortality crisis research presented to you by the Crown Jewels of William and Mary. The team you see on the screen will be the ones you're hearing throughout the duration of this presentation. We will cover our overview, analysis and results, our big idea, and a conclusion.
So first, let's go through our overview. Our what, who, where, and how. What is the problem? Maternal mortality. Who is affected? All women, with a higher prevalence towards Black women. Where is the problem? Everywhere that there are gaps in care. And then how do we help? We have developed a multifaceted statewide approach to save lives and improve health.
To approach the analysis and the results of our research, we identify who is affected and where is the problem, showcasing main data points that indicate Black women have higher maternal mortality, looking strictly at race. So first, having a glimpse into the systemic problem nationwide, we can see that maternal mortality rate per 100,000 live births is 2 times higher in Black women compared to white women. Looking into different medical conditions that impact the pregnancy, we notice that pre-pregnancy obesity is the highest in Black women with a 39%. And lastly, we notice that the maternal mortality is higher in urban areas with an 82%. So we can conclude that racial disparities exist across the country, and while urban areas may provide easier access to healthcare, maternal mortality is significantly higher there. So let's dive into Virginia highlighting potential gaps in care. First, Black women presented a 56% higher rate of receiving inadequate prenatal care compared to white women. 16.6% experienced discrimination during pregnancy, and Black women reported unintended pregnancy an 87% higher rate. So we can see the trend of racial disparities in Virginia as well. And even though there are multiple factors that drive it, inadequate access to care and biases are important contributors to it.
What are consequences of lack of access to care? According to multiple Maria data, we found that 4 out of 15 patients were encouraged to follow up with the specialist. 4 out of 7 patients had no indication of following up or completing their mental health program. 5 out of 9 patients sought mental health professionals from their emergency or medical visit. What we're seeing is success in improving maternal mortality crisis. We know that California is the healthiest state in maternal mortality. Virginia reported 2.6 times higher maternal mortality rate than California between 2016 to 2020. California's maternal mortality rate started declining dramatically in 2006. What did they do then? They established California Maternal Quality Care Collaborative and launched multiple toolkits that could be a game changer for us as well.
So what do we do and how do we do it? This is a 3-pronged approach with toolkits, a new telehealth app, and maternity health check stations. Maternal toolkits are a proven solution in use across California that aim to improve the healthcare response to the leading causes of preventable death among pregnant women. They are a provider-facing instrument that includes best practice tools and articles, algorithms and care guidelines, implementation guides, and more. Telehealth apps would be a free app downloadable on any smart device that gives women access to dedicated obstetric, urgent, and emergent care screening and guidance. Maternity health check stations, through partnerships with retailers like Walmart and chain pharmacies, would allow for basic maternity checks, advice on issues, and a referral to advanced care when necessary. While these would be statewide initiatives with standardization across the board, they would be managed through regional medical centers that house a dedicated OBER that only pregnant and postpartum women can be treated at for any emergent issue. Besides the obvious benefits, the proven toolkits and telehealth apps are specifically designed and implemented to remove racial bias in care.
So how do we do it? What is our call to action? We've developed a two-phase plan, first phase having the first 5 years. We would like to strategically implement toolkits based on the largest gaps in care, then launch a patient-facing app to allow greater access to support and coverage, and finally mandate it, the program to statewide with a focus on mutually beneficial relationships for providers. The second phase, we would use centralized data from the app and toolkits to implement equitable standards of care, and finally establish those public maternity health check stations for further engagement to close the gap.
So what is the takeaway? All of us have come together because we are individuals intrigued by data, and when we see a problem, we want to fix it. Today, that problem is that pregnant women are dying from preventable causes at alarming rates, causes that we can fix, and causes that California has already started to fix. The sooner the Commonwealth can take action to implement toolkits and apps that provide equity and access to care while preventing racial disparities, the sooner Virginia mothers can not only survive, but thrive. Our team is here today with a passion for the cause. We look forward to seeing how our collaborative ideas are implemented at the state level. Thank you.
Again, thank you, Team 4, to the crown jewels from William Mary. Next up, we have team number 5, also from William Mary, the Algo Griffins, Mathical Creatures. Mathical.
Thank you.
Hi, everyone. Thank you for giving us the opportunity to present today and participate in the 2023 Datathon. We are, as he said, the Al Gore Griffin Mathical Creatures. I'm Jenny Karnowski, Shirley Bergstrom, Grace Cavaco, and Maud Wikipedia. We also have Josh Beiser, who wasn't able to attend today because he's presenting his capstone presentation. Thank you again.
Hello, we are the Al Gore Griffins, Mathical Creatures, representing the College of William and Mary in the 2023 Virginia Datathon, and we're presenting our data-driven insights and solutions on mitigating maternal mortality in Virginia. Our team consists of Grace Cavaco, Josh Beiser, Shirley Bergstrom, Madhvi Kapadia, and Jennifer Karnowski. Our analysis sought to answer the question, what significant factors contribute or drive the increase in maternal mortality in Virginia, and what can we do to mitigate risk using solutions based on data insights? Using large data sets from the Virginia Open Data Portal, we used XGBoost model, decision trees, Tableau visualization, and report analytics to determine factors that contribute to the increase in maternal mortality. We found through analysis that race, health district, health region, average labor and delivery charges, diagnosis, and maternity level of care were parameters of interest. We also analyzed known determinative factors from the Department of Medical Assistance Services to build upon mitigative solutions. Overall, we found that access to care, prevention education, as well as data availability all had the underlying commonality of socioeconomic inequity. As a result, we chose to create innovative solutions to address this imbalance. Here we show a map of Virginia counties organized by VDH health districts representing levels of maternal deaths per 100,000 residents and maternal care level. Unsurprisingly, areas with poor access to care show higher rates of maternal death. So how do we increase access to care? We came up with several ideas that, if implemented, would decrease many of the predictive factors leading to maternal mortality. The first is telehealth. Implementing telehealth programs that allow patients to connect with healthcare providers remotely is particularly helpful for individuals in rural areas who may not have easy access to healthcare facilities. Likewise, community health centers would help to mitigate this problem. Investing in community health centers that provide primary care, dental care, and other services to underserved populations is a less expensive option than establishing hospitals or traditional medical facilities while still providing access to care. Utilizing other public services like libraries or schools to establish telehealth centers may help in situations where many lower income communities may not have access to quality internet. To reach these populations, we suggest partnering with other public services to establish telephonic and dedicated computers with private pods or rooms that mothers could use to receive care without the concern of transportation, personal connectivity, or negative community stigma. Another idea is to create practitioner incentive programs. Virginia could allocate funding to programs that agree to train and license nurse practitioners and physician assistants in exchange for a term of service in underserved areas. Additionally, a program seeking to alleviate student loan debt for OBGYN residents could incentivize providers to practice in remote or rural areas for a dedicated period of time. If other centers are infeasible, mobile health clinics that travel to underserved areas and provide basic medical care to patients who may not be able to travel to healthcare facilities would allow providers to care in underserved areas without residing in the region. All of these solutions address our next finding as well. This visual shows average total labor and delivery charges for mothers between the years 2018 and 2022 broken down by patient race. The trend shows that overall care costs have been increasing at a fast pace in the last 5 years. Additionally, Black mothers have notably higher healthcare costs. We can interpret these findings to indicate that emergency intervention occurs at a higher rate for mothers of color. We determined that this correlates highly with quality patient medical data and access to prenatal care. Providers are more likely to intervene with emergency cesarean sections in order to protect the health of the child if the medical status of the mother is unknown. By increasing access to care, using our solutions, we facilitate pre- and postnatal care in a formal but non-traditional setting, which allows for patient-level records and medical history gathering, leading to better data availability and quality. We also noted that we needed more access to data pertaining to births that occur outside of the hospital setting. In a huge win for Medicaid expansion, the Commonwealth of Virginia approved a policy permitting a 12-month supply of contraceptives to increase health equity and reduce unintended pregnancies. We would like to build on that win. So many prescription services today are available through an online intake form and a 5-minute telehealth call. We'd love to see that methodology extended to contraceptives and the delivery of contraceptives. If transportation is a limiting factor to the proper use of birth control, we could see this corrected through at-home delivery. Additionally, knowledge about the proper use and entitlements should be available in multiple languages so that women of color are not left behind. We believe if our solutions are implemented, we would see a stagnation and eventual decrease in the rising maternal mortality rates due to socioeconomic inequity. The proliferation of these services would lessen the consequences of poor access to care and will allow for iterative improvements within social programs. Thank you for your time and for the opportunity to make a difference for our mothers and in turn, the next generation of individuals seeking positive change.
Thank you, Alga Griffins. Again, that was team number 5. For those, again, reminder, People's Choice Award will be coming from all of you as well at the end of the day. All right, so there are a lot of teams that have joined as teams, but we also had individuals who really want to be part of the Datathon. This next team, again, for those following along at home, team number 6, the Traveling Wilburys, were some individuals that collectively formed a team as well. So thank you all. Team 6, the Traveling Wilburys.
Hi, everyone. We're the Traveling Wilburys. I'm Syed.
And I'm Josh.
And the rest of our team opted out. So it's just us. And I hope you like our presentation. Thank you.
Good morning. I'm here with my team, the Traveling Wilburys, today, presenting our solution for the Virginia Datathon 2023 on unmasking maternal mortality. My name is Sayed, and I'm a statistical analyst. My teammate Josh is a process analyst. The dataset we are using today is from the Maternal Mortality Review Information Application, or MARIA for short. It contains information on 35 women in Virginia who died within 365 days of pregnancy in 2018.
Hello, my name is Josh, and today I'll be talking about a single entry in that data set, entry 00FD, or short, I'll call her Maria. Maria lived in Charlotte County, just 2 hours drive away from here. She was a caregiver. She graduated high school, and she never married. Sadly, in 2018, she wouldn't make it to Christmas with her family. She died on December 5th. Her cause of death? Accidental overdose. This comment was attached to her death certificate. The decedent, the 27-year-old white female with a history of drug use, who was found unresponsive. EMS was called and attempted CPR. He was pronounced dead at the scene. Pay attention to those words, found unresponsive. Like many others, she was alone. She died. Her death was considered accidental, and she wasn't alone. Although accidental deaths were not the majority among these 35 women, in 2018 there were 35 such deaths. Almost all of them were accidental overdoses. The warning signs were there. Maria was diagnosed with depression and anxiety. She was receiving treatment for both of those. Again, she was alone. 100% of the women who died of an accidental overdose were previously diagnosed with a mental health condition. Out of that 100%, the system did not identify 33% of them as suffering with substance abuse, meaning that 66% of them had a known history of substance use. According to the National Institute on Drug Abuse, there's a 60% propensity for substance use and mental illness to coexist, meaning that Maria was a very much high-risk patient because her mental health conditions were previously diagnosed. "83% of the deaths in data were avoidable, about 29 out of 35. Maria had stopped her treatment for depression, anxiety, and substance use by herself. She was among the 85% of people who died of substance abuse, but did not receive treatment for substance abuse after pregnancy. 46% never received treatment at all. All of whom had previously known mental health conditions. Maria's case was reviewed by the MMRIA, and they provided the following recommendations. First, put a system in place to make providers aware of when someone like Maria stops their treatment, especially for addiction treatments. Second, set up a standard of care to follow up with those patients when they do trigger that system. Out of all the critical factors contributing to a death in this dataset, access to care is the dominant category by a lot. And there are a lot of recommendations made by the MMRIA reviewers to that effect. I do mean a lot. On screen now is only 8 such recommendations out of 75 unique recommendations. They all had a central theme together. Therefore, when concerning women like Maria, who died of an accidental overdose, our recommendations echo that of the MMRIA. Educate patients and providers on this substance abuse, and implement follow-up policies for at-risk patients. Thank you.
Thank you again to the Traveling Wilburys, team number 6. Up next, we have Team 8, Ignite Excellence. Then Ignite Excellence. I'm actually saying it the right way. From Verizon, BMAS, and George Mason.
Hello everyone, my name is Harish Rangwala. I am Binil Jain.
I'm Garima Oza. This is my third Datathon with my husband Praveen, who's online. And we also have two more team members, Shashank and Anurag, who joined us. It was interesting to collaborate with this GMU team and find really sobering findings about this situation that we are in today in Virginia. It was good to see Virginia is taking a lot of initiatives and doing a lot of things. And we hope that with data analysis and the findings of this group, we could do even better. Thank you.
Okay, so thank you.
It's true, isn't it? It takes a village to raise a child. Yet, pregnant women can often feel alone and vulnerable. The issue of maternal mortality is not just a statistical problem, but a heart-wrenching reality for countless families across the nation. This is especially true for Black women who continue to be left behind despite the progress made in reducing maternal deaths overall. It was sobering to read about Eli, who was eagerly anticipating the birth of her child. However, just 10 minutes after giving birth, she went into an emergency state and unfortunately lost her life. Our initial research showed that Virginia has taken lots of initiatives to address maternal mortality, like baby steps and improving Medicaid coverage. So to find the gap, we decided to dig deeper into data.
We, the team Ignite Excellence, want to bring your attention to the alarming disparity between Black African American women. We are using this path for unmasking the maternal mortality by focusing on the age group of 15 to 54 years. We are utilizing an adjusted maternal mortality rate formula that takes into account the number of African American maternal deaths per every 100,000 live births for African American women. We are focusing on states neighboring Virginia, where Black African American women population is more than 15% of that state's women population in the age group of 15 to 54 years.
We did our analysis on wonder data from CDC on underlying causes of death and also nativity. We focused on states that have a population of more than 15% Black African American women. We used the adjusted maternal mortality rate for Black African American women in doing this analysis, and we compared these comparable states. So we have the percent of Black African American women population, the percent of births amongst these women, and also the adjusted maternal mortality. And we plotted trend lines that show you maternal mortality and then a higher level of maternal mortality amongst Black African women. So these some of the gaps are closing in, some are increasing, but across the states, you see that Black African American women are at a higher risk for the maternal mortality rate is higher and the trend lines are going upwards. We saw in MMRI data that maternal mortality rate is impacted by all causes of death during pregnancy and even after a couple of months of live birth. So we extended our analysis to all causes of death. We looked at death caused by all ICD chapters, and we plotted graphs that again show a disparity. African American women are at a high risk of death across all the ICD chapters, much higher than the percentage of the population. We further looked at deaths induced by drug and alcohol. Again, we find a similar kind of a pattern where states have population that is about 16%. In Virginia, you have about 22%, and the higher rate of African American women deaths. We extended the study further into injury and firearm related deaths. Again, we saw a similar pattern. So the analysis brings us to the point that there's disproportionate risk for Black African American women, and there's a need for an integrated approach to address all these risks. We can take this study further for if granular data of maternity mortality is available within counties and regions within Virginia, or we can look at all causes of death across these counties and work backwards on leading indicators that point to maternal mortality within these regions.
And now, call to action. We cannot ignore the statistics that show Black African American women have a higher mortality rate than any other race in America. There are few small steps that we can take to empower these women. Developing an app for health tracking can help with timely intervention and treatment, creating supportive communities that foster awareness. Passing the bills that protect Black African American women can provide them with a stronger legal footing to fight against discrimination, racism, and unequal access to healthcare. We want to leave you with an empowering message.
On and act on our responsibility to bring visibility to the most vulnerable, to bring freedom to those who don't have a choice, to bring volume to those who are using their voice. We clear a woman's way. We don't fear the day she steps into the light because we are with her for every step of that fight.
Thank you, Team Ignite Excellence. All right, just for timekeeping, we're going to go through two more teams and we're going to take a 10-minute break. So I know some of you may need a break. We'll take a break after just two more teams. Our next team up is Big Data Energy from George Mason University. Big Data Energy, I believe, may not be in person. If you are online or virtual, feel free to unmute and introduce yourself. And if not, that is okay as well. Had a couple class conflicts this morning as well. All right. So again, for those following along, this is Team 10 from George Mason University, Big Data Energy.
Hello everyone, we are team number 10, Big Data Energy from George Mason University, Master of Data Analytics Engineering. My name is Müge Yalçın and my teammates are Andrew Quiroz and Manifon Suriwang. Our presentation today is talking about predicting premature birth risk using machine learning. Here's a quick overview of our presentation and the contents. In this presentation, we will discuss a logistic regression model developed to predict gestational age risk in Virginia. Now, let's take a journey through the development of the logistic regression model and how it can be used to predict gestational age risk. According to the Center of Disease Control and Prevention, approximately 10% of the babies born in the United States are born prematurely. It's crucial to identify the risk factors early on. And how can we do that? So here comes in the magic of good old big data and the magnificent world of the artificial intelligence. As we see the importance of identifying risk factors for premature birth to ensure the best possible outcomes, we started looking for ways how can we use artificial intelligence and data analytics techniques to achieve this goal. And one way to do this is through the use of logistic regression models, which will allow us to identify predictors that are associated with an increased risk of premature birth. Along the road in our journey into the big data world and how it can help us answer the questions, we will cover the data source and variables used in the model, the results of the logistic regression analysis, and the implications for the healthcare professionals. Through this journey, we hope to provide valuable insights into the use of logistic regression models in predicting premature birth and how they can inform clinical practice. To address this complex, our team asked the question, why do we need to analyze predictor variables? After examining the data, we recognized the value in analyzing predictor variables, and the dataset included a range of variables related to maternity care in Virginia. We aim to develop a model that could accurately predict gestational age risk based on the available predictors, and logistic regression models allowed us to identify the most important predictors and their relative strength in predicting gestational age risk. Overall, we hope that this presentation will provide a valuable overview of logistic regression analysis and its potential to improve clinical practice and ultimately lead to better outcomes for the mothers and the babies. So let's now look at how we did it. To develop the model, we used Python and other packages to perform the analysis and machine learning. We used the data API connector to access the dataset, and we worked through our workflow using Anaconda to streamline the process. Here is a quick glimpse of the development process of our model, displaying the logistic regression model map and part of the coding process. The logistic regression model showed that several variables were significant predictors of gestational age risk. Specifically, maternal diabetes was found to be a highly significant predictor, highlighting the importance of managing diabetes in pregnant women to reduce the risk of premature birth. The coefficients of the model were used to identify the most important predictors, with higher coefficients indicating greater importance. Our significant predictors included birth weight, gravidity, and prenatal care visits. By identifying significant predictors of gestational age risk, the model can be used to inform clinical practice and improve outcomes for mothers and babies. For instance, the identification of maternal diabetes as a significant predictor highlights the importance of managing diabetes in pregnant women to reduce the risk of premature birth. The implications of the logistic regression analysis for healthcare professionals is the potential use of the model in clinical practice to identify and manage risk factors for premature birth. Taking our most important predictor, maternal diabetes, for instance, the healthcare professionals can use this information to develop targeted interventions for women with diabetes, including more frequent prenatal care visits and closer monitoring of blood glucose levels. In conclusion, the logistic regression analysis presented in this presentation provides valuable insights into the predictors of gestational age risk in Virginia. The identification of maternal diabetes as a significant predictor highlights the importance of managing diabetes in pregnant women to reduce the risk of premature birth. Our team gained valuable insights using data-driven approaches to identify risk factors for premature birth and develop targeted interventions is crucial. By using the information presented in this analysis to inform clinical practice, healthcare professionals can improve the quality of care for pregnant women and ultimately lead to better outcomes for mothers and the babies. As for healthcare professionals, it is important to use data-driven approaches to identify the risk factors. We encourage healthcare professionals to use the approaches, including the information presented in this analysis, to inform clinical practice, to identify high-risk factors and improve the quality of care of pregnant women. So to sum up, the logistic regression analysis identified several significant predictors of gestational age risk, including maternal diabetes, birth weight, gravidity, and prenatal care visits. Maternal diabetes was one of the most important predictors, highlighting the importance of managing diabetes in pregnant women to reduce the risk of premature birth. The identification of significant predictors has important implications for healthcare professionals working in maternity care, including the development of targeted interventions to improve outcomes for the mothers and the babies. It goes without saying that together we can improve clinical practice and ultimately lead to better outcomes for mothers and babies by using data-driven approaches. Before concluding our journey, we would like to thank you all for joining us. We hope that this presentation has provided valuable insights into the use of logistic regression models in predicting premature birth and will inform clinical practice to improve outcomes for pregnant women in Virginia and beyond.
Thank you, Big Data Energy, Team 10 from George Mason. Our last team before the break is from VCU, Decision Dogs, and I believe we have a representative.
Sorry, I like to bring the energy. So we're Team Decision Dogs from VCU's Department of Decision Analytics, master's programs. All of us were there. We're all working full-time jobs as well as doing full-time education. We're so glad to be able to participate and be among all these great presentations. Kayla did a great job. I hope you can all enjoy the presentation. Thank you.
Mothers are dying here at higher rates than mothers in any
Women
other.
in the United States are dying from pregnancy or childbirth-related causes at an alarming rate.
In 2021, 3,664,292 newborns were welcomed into our world here in the United States. Though the number of small gifts are large, our country is still at a steady decline in birth rates. On the contrary, there was a 40% increase in maternal deaths from 2019 to 2021. In 2021, there was reported 1,205 deaths due to maternal causes. According to the report by the Department of Medical Assistance Services, the maternal mortality rate in Virginia in 2020 was 15.6 deaths per 100,000 pregnancies. Cardiovascular disease was found to be the leading cause of pregnancy-related deaths in the United States. According to the CDC, between the years of 2017 and 2019, 84% of all 1,018 pregnancy-related deaths in a sample collected from 36 states were determined to be preventable. As a group, this led us to questioning if most cases of maternal death are preventable, where is the disconnect in patient treatment? Throughout most of this experience, our team ran into difficulty in finding large-scale data sets or uncovered inconsistent reporting mechanisms across state governments. One example stems from the Texas Department of State Health Services 2022 Maternal Mortality and Morbidity Biennial Report. The CDC describes severe maternity morbidity as an unexpected outcome of labor and delivery that leads to a short or long-term consequences to a woman's health. Because the majority of untreated conditions identified could result in death, SMM indicators on a hospital discharge paper are used to help report mortality rates and ratios. In Texas, however, an enhanced method was developed that completely goes against the grain and guidelines provided by the CDC. This has led to an underreporting of mortality rates for the state. Another part of our journey included investigating the racial breakdown of maternal mortality in respects to race. As you see in the graph in front of you, women who are African American display a much higher rate in death in comparison to other racial groups. According to the CDC, these numbers can be explained by factors such as variation in quality of healthcare, structural racism, underlying chronic conditions, as well as implicit biases. So, how do we move forward to fight against the increasing rates of maternal mortality? Step 1, it's important to produce more training and encourage medical staff to listen to more African American patients on topic of pain and pregnancy. The process of pregnancy is difficult. A mother should not have to receive unacceptable medical assistance just because the color of their skin or preconceived medical biases one may have. Step 2, there needs to be some form of centralized reporting standards across all U.S. states. Step 3, we want to create a platform at the tip of one's fingers that enables women to find and create circles and safe havens for asking and answering questions, along with connecting with others' stories. The platform would also provide telehealth services for women at either reduced or no cost. Regional resources will easily be detected for each user based upon GPS location. Last but not least, we want women to have a bank of health-related knowledge right in the platform. Health articles will provide extensive research in an easily digestible fashion for users. A quote from Melinda Robinson, an American nurse midwife who has spent over 30 years working in women's health, resonated with our group during the analysis. She shares, "This is not a rare disease, this is pregnancy. It's a normal condition that 80% of women will experience in her lifetime. All women deserve a safe space and respectful way of giving birth. It's a basic human right." Our group may not have all the answers. However, today, we have provided some initial actions to be considered in helping to reduce the alarming rates of maternal mortality. We all need to take charge and change the status of women's health. Thank you.
Thank you, Team 11 Decision Dogs. Okay, we have all, first of all, let me give a second. Well, why don't we give everyone a quick round of applause for the first 8? Okay, so it is approximately 10:40 here. We would like to take a 10-minute break. Before we break, the sponsors have booths out in the hallway. Please make sure you stop by there. The restrooms are directly opposite the stairs. If you walk out beyond the stairs, you'll find the restrooms on the far right corner as you walk out into the, left, well, yes.
To the left of the stairs.
To the left of the stairs, but right from here. There you go. Perfect. And then we will be back here at 10:50 to begin with the next presentation, which will be the paranormal distribution, Team 12. See y'all in 10 minutes. Thank you.
This is great.
We'll watch it.
That'd be great.
We're gonna get these done before lunch, and then have lunch, after the government's gonna talk. We'll have a little break, so probably around 1 or so.
Okay.
Yeah,
You wanna
she should be
text
on it noon.
at noon,
Yeah, we're
okay.
still planning her at noon, yeah, right.
All right, that sounds good.
Sorry, I had to keep running out the things. Yeah. It was really interesting too.
I hope so. I hope it works.
Yeah. Yeah, I agree.
I hope so.
No. People online, so they don't- Okay. It really
Yeah, yeah.
They're up in a second.
Yeah, the bottom cut off.
Okay.
So just in case they wanted to be.
In case they want to be, yeah, sure, I'll do it right now.
It is, it really is.
And
What's the cut for?
That's a good idea. Yeah, we might be able to watch. Okay, now I'm getting extra dollars. Yeah.
Welcome back. We have now made it through how many presentations? Nice. We are going to go 4 more and then break for lunch. So we have 4 just to help set everyone's expectations. We'll go 4. We will do a picture as a group on the stairs, have lunch. We'll be, Secretary McDermott will be in at noon to do a presentation, and then we'll do the final 4 as well after that. So far, so good? All right, let's move on. Judges, are you ready? Judges ready? Driver? No, okay, forget that. All right. We're going to move on to team number 12 from VCU Paranormal Distribution. There, well,
we are trying to continue on VCU energy. Sorry. We are team 12. We are paranormal distribution. My name is Kristen Smith. I'm the Director of Enrollment Research and Evaluation in the Division of Strategic Enrollment Management and Student Success. I'm Ashley Christakis. I work for her.
Hi, I'm James Broche, and I am a business systems analyst for the admissions department.
And we have a 4th partner, Karen Horner. She's watching online. And we decided to give our presentation live. So we're just kidding.
You could tell me, great.
22 out of every 100,000 live births result in maternal death. 90% of these are preventable. Welcome, everyone. We are Team Paranormal Distribution from VCU, and our presentation on maternal mortality focuses on the impact access and equities has on preventable maternal deaths in Virginia. My name is David Sprache, and I am a business system analyst for VCU.
My name is Ashley Christakis. I'm a research analyst in enrollment research and evaluation.
I'm Karen Horner, business intelligence analyst for finance and budget.
My name is Kristen Smith, and I'm the Director of Enrollment Research and Evaluation.
7 million women of childbearing age live in an area where there is no or limited access to maternity care. 1 in 8 babies are born in areas with limited to no access to maternity care.
And so how does Virginia compare nationally? And to be clear, we're defining maternal mortality with a CDC definition, which includes deaths of women while pregnant or within 42 days of the termination of pregnancy. The United States average is 20.4 deaths per 100,000 live births, and you can see here that Virginia is slightly higher than that at 22.3.
Maternal vulnerability, as reported by Sturgo Venture, is when women are vulnerable to poor maternal health outcomes, using a 0 to 100 scale where 0 is the least vulnerable and 100 is the most vulnerable. In Virginia, the highest vulnerabilities were seen in reproductive health care, physical health, and general health care. Virginia ranks 19th in the nation with an overall vulnerability score of 36.
So as we look closer into Virginia, we wanted to understand where the holes in maternity care existed. The March of Dimes, an organization that focuses on infant and maternal health care, defines a maternity care desert as any county in the United States without a hospital or birth center offering obstetric care and without any obstetric providers. With this context, we reviewed the deserts in Virginia and saw that these existed along the peripheral and within central Virginia. Looking further into why these areas were deserts, we saw a small number of hospitals and birth centers scattered around Virginia. In Virginia, 70.7 counties have no hospital or birth center offering maternity care. But it would appear that the major factor with the distribution was the distribution of OB providers throughout the state. In Virginia, 32.3 counties had not a single obstetric provider.
And so looking at prenatal care in Virginia and the availability of access across the state, according to the March of Dimes, 19.6% of mothers receive no prenatal care in the first trimester, some of whom continue to receive no prenatal care throughout the entire pregnancy. And this is obviously a concern because delaying that care puts the baby and the mother at great risk of serious medical problems, including maternal mortality, maternal death. So we were interested in learning more about the known barriers to seeking that prenatal care, to seeking healthcare in general. And the primary barriers we found in our research were cost, typically related to the lack of insurance or the need to prioritize work over receiving healthcare, convenience, transportation, other childcare coverage, or available appointment hours, psychological and psychosocial fears, such as the fear of being judged or fear of others' reactions, and lastly, fear of legal prosecution. typically related to substance abuse or an undocumented residency status.
So how do we resolve these barriers and improve healthcare access for mothers? Mobile healthcare units are already in use in Virginia. They are limited, but have the potential to expand to serve to a wider, more diverse population. Existing mobile healthcare units offer primary care, preventative screenings, dental services, specialty care, including mental health, mammograms, and ophthalmology. Research of adapted mobile health units found that patients were more likely to receive prenatal care earlier in their pregnancy. They reported lower rates of preterm health issues and overall better health outcomes for mother and child. Similar or greater results could be achieved in Virginia by modifying mobile health units to include pregnancy interventions with pre and post care, primary health care, including mental and social health interventions, newborn care and interventions, financial assistance, and human resources. Mobile healthcare units decrease barriers in healthcare, including those that impact maternal mortality, by providing patient-centered care that is tailored to the community it serves, promoting health and social education, empowering patients through advocacy programs and support services, and fostering trusting, reliable relationships. Using a diverse group of healthcare workers who are trained in cultural competencies, specialized in the needs of their community, including mental health, physical health, social work, and more, and by providing convenient services in a comfortable setting, with stability and consistency of service provision within communities, convenience of having a service that is accessible and affordable, and by offering a space that is comfortable and less intimidating than conventional care spaces.
Remember that 90% of maternal deaths are preventable. By expanding mobile healthcare units, we can save lives. Thank you for your time.
Thank you, Team 12, paranormal distribution. The next couple are actually virtual presentations. So Team ER, Exponential Rangers, is Team 13 from J.R. Tucker High School and AWS. Again, that's Team 13, ER, Exponential Rangers. I don't believe they're here physically.
Oh.
You're
sorry.
online. Yep, there you are. Very good.
Hi, so I'm Vanya. I'm a junior at John Randolph Tucker High School. My peers, who unfortunately couldn't join me today, and I are more than ecstatic to present to you our solution called Dual AI. Thank you, and I hope you enjoy our video.
You know, according to the CDC, Hispanic and Indigenous women are disproportionately victimized by maternal mortality.
These data sets reflect one major trend, that not only is maternal mortality a rising issue, women who are obstructed by prevalent language barriers and resource disparities suffer greatly, almost double the amount.
Not only that, but women from all backgrounds experience great difficulty when it comes to pregnancy. Due to the prevailing stigma surrounding maternal mortality, many women are forced to struggle in silence, creating a lack of understanding of pregnancy.
Aren't there already government initiatives in place to help pregnant women?
Yes, but not everyone knows about government programs suitable for them, and the lack of awareness of the available help is another issue, particularly to those who do not have access to this information in time.
After analyzing the plethora of data sets available to us and issues with pre-existing solutions, we realized that there was a better way to deal with the issue of maternal mortality.
Introducing Dual AI!
Welcome to Dual AI, our innovative solution designed to empower and support pregnant women from all backgrounds. Our mission is to combat maternal mortality, break down language barriers, and provide essential guidance to help ensure a healthy pregnancy journey. Dual AI is a comprehensive application offering personalized guidance throughout your pregnancy. It includes a pregnancy tracker, customized meal, and exercise suggestions, AI-driven feedback based on your symptoms, and vital healthcare information. Dual AI is designed to cater to women from various backgrounds, including those who struggle with drug abuse and language barriers. Dual AI's features include, but are not limited to, a pregnancy tracker to inform you of your current trimester and stage, an input system for meals and exercise times, which generates personalized feedback. Furthermore, Dual AI has information on healthcare services and legal guidance, such as finding the nearest hospital, applying for financial aid, and assessing helpful articles on prenatal and postnatal care. These are in the form of articles written by experts and doctors, which are also available in several languages.
The emergency contact integration for added support and safety ensures that women who may be struggling taking care of themselves, like drug users, have quality care either from a significant other or a trusted friend. These friends, doctors, or other people can also refer a person to use our application.
Furthermore, we're fully compatible with popular virtual assistants like Alexa and Google.
as well as smartphones and laptops. And we hope to become integrated with local healthcare providers for seamless communication and care.
And finally, Dual AI offers a forum where users can share experiences, advice, and encouragement with one another.
And like a real doula, this will also inform a user about available government programs when they need it the most. Our application incorporates all of the prevalent disparities we notice that pregnant women face.
At Dual AI, we believe that connection and support are crucial to a successful pregnancy journey, especially to single and teenage mothers. Our forum fosters a sense of community, allowing users to share stories, tips, and research on maternal health care. We are committed and constantly updating our platform with the latest advancement in maternal health to provide you with the best possible guidance.
Hey, I'm Vanya, the team leader, otherwise known by my teammates as Miss Nitpick.
Hi, I'm Lakshan, known as the Java Chamber.
Hi, I'm Abel, known as the Big Data Stepper.
She's Audrey, this is Ninika, and we're the Data Darlings. Together, we're the founders of Dual AI.
Join us today and discover the empowering support of Dual AI. Together, we can create a healthier, more inclusive future for all expectant mothers.
Thank you, team ER Exponential Rangers. Again, that was team 13. All right, moving on to team 15 from Symmetry. Team Symmetry, are you online?
We are online. I'm Steve. I can introduce the group here. We're Symmetry. We're a small analytics, data strategy, and digital consulting firm based out of Arlington, Virginia. I'm joined here by Daniel Crystal, Kevin Johnson, and Patrick McCreesh, and I hope you enjoy our presentation.
Hello from Team Symmetry. Recent rises in maternal mortality in the state of Virginia represent a significant opportunity to leverage data to improve outcomes in the state. We performed a qualitative and quantitative review of information we could find regarding maternal mortality. On the qualitative side, we reviewed recent reports and publications to understand the factors and trends that contribute to maternal mortality. Through a quantitative review of data on MMRIA critical factors, we uncovered a common theme of needing to seek care and failure to get to needed care in time. As we looked through available reports, we thought about how we could align a potential solution that addresses the theme of needing to get care in time to two of the 6 key focus areas from the 2021 Health and Human Resources Plan. These 2 focus areas were healthcare environment and community-based services.
So we went out and got a lot of aggregated demographic data by zip code and plotted it on sort of a map of Virginia. And some of the factors we noticed that we think are the most important are median income as well as race. And as you can see from the map, so we have the median income, you can see the darker purple and blue areas are where income is the lowest, and the greener and yellow areas are where it's the highest. And as you can see, a lot of the maternal deaths happen in areas with lower income or lower income compared to the general region. We also noticed that they weren't just happening in either rural or urban areas. As you can see, sort of there's clusters in Northern Virginia, Richmond, and the Norfolk area, as well as a bunch of maternal deaths scattered throughout the more rural western part of Virginia. We wanted to look at other factors that could potentially be involved. So some of them are knowledge barriers or transportation barriers, but as we went further along, we decided to build a risk model that really looked at individual data.
As Kevin said, we have to get past the aggregate data to the individual level of data. As you can see here, that will allow us to build a person-centric risk assessment model that will allow us to assign a risk score to each individual. We recommend using the score from prenatal all the way through postpartum. From that, we can apply that risk score of high, medium, low to each individual and then get them the right services based on their level of risk. In order to build that risk score, we need to bring in the data that supports the risk factors that we've identified that can identify those women at high risk. We would also want to include information that was not available to us for this study, such as access to public transportation and appointment information history, which would allow us to be able to build a more robust model, including those individuals who had missed their past appointments as a predictor for whether or not that could lead to some sort of maternal mortality. Once we have that data combined, we can build an effective risk assessment model, as Steve will show you in a moment.
We built a sample risk model for the entire population of available MMRIA deaths, but we're only highlighting those available in the Norfolk-Suffolk area in this case study. We began by quantifying key data points from the MMRIA data, such as known mental health diagnoses, which were prevalent in many of the cases, or prior hospitalizations, or substance abuse history. We also gathered data from publicly available sources on the nearest health facilities, such as hospitals, or substance abuse treatment facilities, or mental health facilities, and even OBGYNs to create a distance calculation to those individual addresses. The combination of these variables were treated as risk factors within our model. While we created our own weighted methodology, it can be adjusted in coordination with SMEs. We believe that the best risk model is a combination of data revealed and heuristics from the SMEs. While we weighted the distance of certain health facilities the heaviest in our example to demonstrate the potential impact and influence that being farther away from facilities might make you a higher risk individual because it makes you harder to get the care that you needed. Our final model would be able to prioritize and bucket these individuals into those programs to identify the most appropriate approach to get these individuals the care and assistance that's needed. Now, to supplement our risk model, we are also proposing the creation of a mobile application that takes an individual's location and helps them identify the nearest location of key services, whether it be hospitals or substance abuse treatment facilities or mental wellness centers. Now, the idea is to provide as much information at the individual's fingertips to streamline the process to getting the required support. Now, the risk score may not necessarily be shown to the individual, but we believe it can be integrated as part of the application. So higher risk individuals could and should receive more push notifications to make an appointment. They should get more information around key risk factors or early warning signs that might be associated with a particular case. We also like the idea of the creation of mobile health units, clinics, using the geolocation of individuals from the phone app to send the mobile unit to. This concept has been successfully utilized in rural areas, but we are proposing the expansion of these mobile clinics to urban areas as well, to go again, to get the individuals the services that they need. In summary, we feel that by creating a risk assessment and creating a mobile app that's able to push notifications to those individuals in need, the Commonwealth of Virginia can begin to close the gap to maternal mortality, because even one death is too many.
Thank you, Team 15 Symmetry. Our last team before lunch is going to be Team 18 from VMI, Virginia Military Institute. Team 18 is back in the room. Please welcome VMI.
Good morning, everybody. My name is Mitchell.
I'm Jesse.
I'm Thompson. Like I said before, from Virginia Military Institute, this is our first year at Datathon as a school and as a group. And I'm very honored to be here today, so I thank you all.
Good afternoon, everybody. My name is Mitchell Meyer with the team VMI, team number 18, and today we're unmasking maternal mortality. And to begin, we chose this case from the CDC in the US in 2021. There were a total of 3.6 million live births with an alarming 1.2 thousand maternal deaths. And although this number is relatively small, these lives shouldn't go overlooked. And in the data, the deaths seem to be rising. And so we need to define what maternal mortality is. And so also taken from the CDC, we take the definition as the death of a woman while pregnant or within 42 days of termination of pregnancy. And so we took this definition as a standard and was assumed during statistical review. And so why is this important? And as previously mentioned before, these cases are small, however, they're unaccounted for and rising. They need to be understood and minimized. And this is very important to our posterity as mother gives birth to our children. And so the goals for this are to unmask and find underlying factors that affect maternal mortality. In conjunction to unmasking this, we want to find a practical solution at the end. And so what is the problem? Like said before in the goal, the study aims to unmask maternal mortality, and this will be completed by analyzing data that exhibits differences based on race. And so I'm going to pass it over to Komsun to take over statistical analysis.
Hi everyone, my name is Komsun. So this is a scatter plot for maternal mortality rate for Virginia versus United States. It is obvious that it's much higher rate in Virginia than the one from United States, especially the year 2008. This can be the result of the Great Recession during the year 2007 to 2009. The economic problem can cause the maternal mortality rate at the time. So we use earlier data to make a model by regression tree. We extract what are some important variables. The result from this are ages and race. These two are highly important and more significant than the others. After that, we did partial dependent plot for age and race separately to see how these two predictors affect the rate of maternal mortality. According to the plot on the left, it is more likely to be higher in risk for women above 40 years old in mortality rate, while it much lower rate of mortality if mothers are 25 years old or under. Another graph on the right is the risk associated with maternal mortality rate. We found that non-Hispanic African American has much higher rate of maternal mortality. White mothers is lower and Hispanic is the lowest. So I put two of these predictors to see a bigger picture in a 2D partial dependent plot. We can see from some cases women over 40 years old and non-Hispanic African American in the light blue plane, they have the high risk for mortality rate. Comparing with the Hispanic under 25, they have the lower risk of mortality. Now I'm gonna keep over to Jesse to talk about numbers, stat, and solution.
Hello everyone, I'm Jesse. Due to a lack of usable recent raw data on maternal mortality rate in Virginia, this study was left to comprehend the state using published hard data. Between the years of 1999 and 2012, there were a total of 628 deaths, broken down by race in the table shown. Unlike the total U.S. maternal mortality rate, Virginia has a higher number of white women deaths. However, African American women deaths are still at a high number. The disparity between the U.S. and Virginia datasets could be explained by a difference in population composition. In Virginia, the main cause of death for all races was related to healthcare, with the leading cause of non-Hispanic African American being cardiac disorder, non-Hispanic white being accidental overdose, and others being disorders of the central nervous system. So what can we do? Our recommendations are to ensure that public health care plans ensure equal opportunity and care to all regardless of race, to teach healthcare providers about risks and factors that attribute toward race-specific maternal mortality, and provide healthcare workers with knowledge about these disparities and strategies to minimize them. Thank you for your time.
Thank you again. That was team 18 from VMI. All right, so we are now, I'm standing between, I think, you all and lunch. It is 11:30. What we're going to do before you grab lunch, we are going to exit the doors as a group and walk past lunch. It'll be challenging. You can grab a slice if you want, but we're going to walk past lunch to the stairs for a quick group picture. After the group picture, we will actually come grab lunch, eat in here or eat wherever you'd like. We'll start back. I'd like to ask you to be back by 11:50. Because we have a speaker, Secretary of Administration Lynn McDermott will be here at noon to give some remarks as well. So we can eat lunch here. Also encourage you during lunch break, maybe sit with someone else, sit with other people, get to know some of the folks around here. I will tell you, having done Datathon for many, many years, people that I've met, Datathon 1, 2, and 3 are in this room today and are still not just like friends, but closer in friends. So again, take time to get to know people around the room as well, beyond your teams during lunch. So right now we're going to walk to the stairs. We'll get a group picture, grab lunch, and be back here by 11:50. Thank you all again. you go. We just all right.
Yes. Next year. But we need to see it here. Yeah. That's why we not challenge. Right. We gotta share that and say, like exactly that's how we see that. You know, we need to try to do this. So they just
Just a 1 minute warning. We'll get started in 1 minute.
I can't make it higher, right? 500 or some job and, you know, what are you? It doesn't make your computer go to sleep. You know, the second.
If people can make their way to their seats, we'll get started here in 30 seconds. Countdown timer?
They're gonna be away from their desks. So. Oh, yeah. People are just funny.
Welcome back. Thank you. Good afternoon. Well, first of all, thank you all again. We are halfway through the day. It has been an amazing day. I can't thank you all enough. As I said this on the kickoff, each of you have made a commitment to the Commonwealth beyond just talking about an issue, but actually taking your time away from class, family, work, to not just talk about it, but actually be part of the solution. I have an extreme honor right now to introduce Lynn McDermott. Of all the individuals here, Lynn is a person who doesn't just talk about challenges, but actually jumps in with both feet. We are super proud of Lynn. She was the first woman accepted at the apprentice school at Newport News Shipbuilding. If you all have not been to the apprentice school, there is a phenomenal asset we also have in Virginia, and also just a role model for many other states and organizations in the apprenticeship program. She received her BA from Mary Baldwin College and an MBA from University of Richmond. She was chair of the board of directors for the Federal Reserve Bank, chair of board of trustees for Mary Baldwin College, chair of board of Greater Richmond Technology Council, and currently the co-chair or chair of the Child Fund International Board. Lynn was named Computer World's list of premier 100 IT leaders in 2004, received the 2008 Executive Women's in Business Achievement Award by the YWCA, and is Rich Tech's Chairman Award in 2013. Secretary McDermott leads the Secretary of Administration, which ODGA falls underneath, and has been a huge champion of transformation across the Commonwealth in all things she does. It is my pleasure to introduce Secretary of Administration, Lynn McDermott.
And I'm not 100 years old. So first of all, I have heard such great things about what you all are doing. So it's just so exciting. And thank you for inviting me to speak from the governor, Governor Youngkin. He wanted me to welcome you and to thank you also for the work that you're doing on data. As you have already heard, I think, and will continue to hear, he is all about data and is very interested in all of the work that you all are doing. Special thanks to the Library of Virginia, to AGDA, to the judges, to the sponsors, and to everyone else who has made this event happen. I know it's not easy. I know it took a lot of time and effort, but what a wonderful job you all have done. So thank you very much. I know it's been an amazing week and a lot of hard work, and I really look forward to hearing about what you've done. It's really great to have some of the best and brightest young people in the state convene together here to solve what is, as Deputy Secretary Mills said to you this morning, a significant issue and problem within the state of Virginia. So just a few words about me, a lot fewer than Alex had. I never imagined in a million years that I would be in the cabinet of Governor Youngkin. I had retired twice, was very happy being retired. But despite that, when I got the call, I came because I love Virginia. We raised our children here. I take credit for them. And our grandchildren live here, and we just love the state, and we want to invest in the future, as I know you all do as well. As Secretary of Administration, I'm responsible for a rather eclectic group of agencies. I have the Department of Elections, all about data. I have OGDA, lucky to have them because they're helping all the other agencies. I have the Department of Human Resources, the State Compensation Board, and VITA, the Virginia Information Technology Agency. So it's all about data for us. Data's been a critical part of every job I've had. Without it, we can't do our jobs. As leaders and as practitioners, it's all about the data. But it's been important a lot longer than I've been around, even though that's a long time. From 18,000 BC, when the Paleolithic tribes people marked notches on their walls to keep track of their trades, data has been critical to their success. In 1663, John Grant carried out the first recorded experiment in statistical data analysis by recording information about mortality, what you all have been working on today during the bubonic plague that swept through Europe. He theorized that he could design an early warning system for the bubonic plague and help to remediate it and fix it a lot sooner. In 1880, the Census Bureau had a problem. This one, when I read it, I thought, this is crazy. It estimated that it would take 8 years to crunch all the data for the 1880 census. And for the 1890 census, it would take them 10 years. You don't have to be a rocket scientist to realize that they wouldn't finish the last one before they started the next one. A young engineer, like many of you are or will be, Herman Hollerith produced the Hollerith tabulating machine using punch cards that reduced the time from 10 years to 3 months. He's considered the father of modern automation and later founded a company. Anybody know that company? IBM. Good for you. There are many, many more. Do you work for IBM? There you go. There are many, many more examples, but I'll give you one more bit of trivia. In 1999, the Association of Computing Machinery published a paper using new terms, 1999, big data and the Internet of Things. That's almost 25 years ago. Now we talk about data as if it was ubiquitous all of the time. Data warehouses, data lakes, data sets, data repositories, data virtualization, and data. I am aging myself now because I remember when we provided the business with printed reports, and that's all they got when it came to data to do their jobs. So here's a question for you. If you had the ability to create over $1 trillion of value across the nation, would you do it? I think the answer is yes. McKinsey's Global Institute estimates that data and data analytics can do annually for the public and social sectors just that. Leveraging data and analytics clearly has the potential to transform government at all levels, and it certainly has for the Commonwealth of Virginia. But what I have found is data at the state and local level often sits in silos. It sits within agencies. Fortunately, in 2019, the General Assembly promulgated a law that said we need to share data. And OGDA became got around right around that time, right, Marcus? Data sharing and establishing that office has been growing within the Commonwealth's Data Trust to facilitate the sharing of data and information across agencies. As a result, Virginia has been leading the way in data sharing through the Open Data Portal. The Open Data Portal is managed in partnership, that's a word to remember as you begin to go into the workforce, between the Library of Virginia and the Office of Data Governance and Analytics, our host for the Datathon. The Office of Data Governance and Analytics also provides a common platform for sharing data. So that was the first thing that Marcus and his team built, is the foundation of the actual delivery of those services. And they also provide common platforms for sharing non-public information between agencies, confidential government information. Using that common platform reduces costs, increases speed, and most importantly, ensures the security of the data. As Deputy Secretary Mills mentioned this morning, data plays a huge role in Governor Youngkin's administration. As she said, he believes in data-driven decision-making. And there are so many ways and so many problems that we can solve if we have good data. The problem posed in this Datathon is a really great example of that. And you heard about that from Deputy Secretary Mills. You also heard her describe how data influences policy. So it's not just solving problems, tactical problems, it's influencing the future by influencing how policies are made and written. Chief Data Officer File has a lot of bosses. And one of his bosses is a committee that's made up of senators and delegates and university people and citizens that advise him and his team on our data policies and data practices. They're the ones that insisted that we have this Datathon. They know just how important the work that you're doing is to the future of the good use of data throughout the Commonwealth. I know there have been and will continue to be information that you have illuminated within these, whatever it is that you've developed, that will be great help to the healthcare people and the experts in the department and the agencies in the health and human resources area. And speaking of agencies, I just want to continue to shine a light and sincerely thank the Library of Virginia and AGDA for sponsoring this work. The Library of Virginia, as you've been told, works to preserve data and information from the past, while AGDA looks at the present and the future. So it's a great partnership to be able to marry the two organizations together. So thank you very much. What we want to create is business value. The future is in how can data help the business? How can data help society improve itself continuously over time? From the time people were etching, not just on caves, to now, to whatever the future will bring, is what data and data management, data availability is all about. So congratulations to you all. In addition to these two wonderful state agencies, there are many other areas of the administration that are using data. And I know that Deputy Secretary Mills gave you some examples out of her secretariat. Let me just give you a couple of more. The Department of Criminal Justice Services, who are working with ADCA, with local, regional, and statewide partners to use data to form scorecards and statistics about the opioid crisis, a significant issue within the state of Virginia and the entire country. So how can we use data to know where to focus the efforts, where to spend the money, where to fix the problem? Our transformation department, as you know, the governor, one of the first things he did is bring in a chief of transformation to help us work through improving our processes. ADCA created for them a dashboard for all of the various initiatives that we're working on. In healthcare, social services, public safety. Another one, and this will be my final one, even though I have a lot of them to talk about because I'm so proud of the group, is called Operation Bold Blue Line. Operation Bold Blue Line, and you read about it in the paper every day, is an initiative to stop violent crime. It's providing data to the governor and to the localities about what's the patterns. We have a shortage of police officers and law enforcement. Where should they be? Where's the best investment of their time in solving violent crime? And that's exactly what Bold Blue Line is doing. Okay, I'm a little bit ahead of myself here. And I won't bore you with all the great work that we're doing. So these are just a few examples of the many use cases on how data is making a difference in the lives of citizens of the Commonwealth. And this administration is not finished yet. The Commonwealth of Virginia knows that you cannot manage what you cannot measure. How many times have you heard that in your education or career? And we take it very seriously when working towards improving the lives of Virginians. We also take very seriously our public service commitment, that's why we're here, for Virginians. As you already know, the effective use of data can make real world benefits, but there are still some issues that you all need to help us solve. The most obvious, I've mentioned already, is data sharing. My first experience with the lack of data sharing was as I was in charge of cybersecurity. And the various entities would not share. I need a glass of water. Is there some water? I'm getting all choked up. Seems like all I do is talk all day, so I apologize. Anna and Marcus know that. So data sharing is a real problem, has been a real problem. Agencies and entities like to keep their data. It gives them control. They also are worried about security. So in the cybersecurity space, we had a huge effort that the three-letter agencies in DC would share their, I've got it, thank you, Natalie, would share their information with other critical infrastructure providers like energy or railroad or telephone. And they're doing that now. We get regular updates from those agencies that know more of what's going on than we do about what to look out for in the cybersecurity space. At the same time, we have to protect private information, PII, HIPAA, and other forms of personal information. We just need to make sure that it can't be exploited for harm. So there's a real balance between sharing information and protecting information that experts like you have to figure out and keep us working down that path. We also have technical challenges. Storage. How much storage do we need? How much storage do we have? How can we minimize the amount of storage? How can we go to the cloud in a way that is economical for the businesses that we support? There's probably some chart that shows the exponential growth of data and storage and the cost that that's creating for all of us. Once we have a large amount of data, we also need to be able to process it quickly. Process what we all call scale to scale. Those are some of the problems. So it's really important that you all stay engaged in this. The cloud allows us to burst capacity, but we don't have enough in the cloud yet. All this power doesn't help us if the data is stale or if the data isn't accurate. So data quality, data integrity, knowing what the data really says, not just what you think it says, being able to correlate and collate appropriate data that creates affinities for that data is really important. The future of data and analytics is in real-time data processing. Should we have to wait a week to get data? Or should we know right away that a crime is happening in this locality and we need the police there? Or we have a long waiting line at the DMV. We need to put more agents on the desks in this particular location. That's another project that Marcus and his team worked on. Many decisions today, if not all, are based on data and reports of that data. So real time is going to help us. Uber's probably a great example of that, where they have real-time data available. They use it to surge their prices. So when there's a high demand for Uber, the prices go up and we all are willing to pay it. Perhaps we could mobilize resources during a natural disaster much quicker if we had real-time data. So stale data is one thing, ill-defined data, misclassified data. How do we get to the right data at the right time to make the right decisions? Data doesn't have to be loaded in a data lake anymore. New concepts in the industry, like a data mesh. You all probably know a whole lot more about that than I do. Decentralizing and federating data such that it can be assembled quickly so that we don't have to have a kind of a huge data lake out there that we're paying to maintain all the time. So the innovation that you all are creating by going through these exercises, by forming these teams, is really, really important to everyone and to the state of Virginia and to what we're trying to do in the Youngkin administration. Imagine using predictive analysis, that's Ken's favorite thing, to determine when maintenance needs to be on your car and not just use the boilerplate every 6,000 miles, have your oil changed, but so that you actually know based on the performance of the engine that the oil needs to be changed. These are some of the use cases that are going to come out of the great work that you all are doing. The opportunities to improve the Commonwealth through the application of data and data analytics are endless. To harvest the value data that can bring, we need to drive data literacy for all of our citizens, not just those focused on data and data analytics. Our educators are key to driving the development of the next generation of skills like data analysis, data science, machine learning. And I'm a little reluctant to talk about ChatGPT and AI at this particular point in time. But I applaud the efforts of the educators in this room and across the Commonwealth who are making sure that our workforce for the future has the skills needed to be a leader in data analytics and drive positive outcomes. To all the team members here, we appreciate all of your efforts. We appreciate you. I hope you had some fun. It sounds like you did. I hope the pizza was good. Remember, next to our people, data is our most valuable asset. I encourage you to continue your work to protect the data you have the privilege of working with, to make it available to the businesses that you support now or will support in the future, to continue to innovate and have great ideas about what's the next great thing, what's the next best thing, and try new things. Fail fast. Try it. If it doesn't work, toss it and try something else. So to quote our governor, and you've heard this quote before and you will hear it again, our job is to help you make Virginia the best place to live, work, and raise a family.
Thank you again, Secretary McDermott. All right, we are down to the last 4 team presentations. I'd say we'd save the best for last, but that would be showing all our best. Judges, you ready? Oh, absolutely. So as Secretary McDermott mentioned, and I think I mentioned this in the virtual kickoff, we in the Commonwealth are uniquely positioned to share data. There are not many other states that have had the investment of data, process, funding, and cross-agency support that we have here in the Commonwealth. I think I shared this story, but we were at the National Governors Association meeting 2 years ago, presenting with an agency, and I asked all the states. We were doing a discussion on public-private partnerships and data sharing. I asked every state, how many of you all have a data sharing agreement or a data trust? And like 30% of the states have those things today. And I was shocked. And so people ask me questions like, hey, what should we focus on? How do we get there? I was like, well, throw all that stuff out the window and focus on getting data sharing. Because once you have data sharing, you'll have access to more information outside your silo, and you'll make more data-informed decisions. So again, I think we are well positioned. I know she and the ODGA staff are outside the room, but I think they have done a phenomenal job of positioning us for success. All right, so we are now off to our last 4 presentations. Our next team is Team 20, City of Norfolk Team Norfolk, and they are here today. Put your hands together for Team Norfolk.
Hi, we are Team Norfolk. I'm Carl Larson, Lori Powell, Kathy Feinholm, Hannah Skudlarek, and then we have Natasha Singh Miller and Jasmine Lane on the phone. Thank you so much for listening to our presentation. It is focused on access to care and looks at drive time of mothers, and also takes a look at the possibilities of telehealth and identifying women who need additional access to care. So thank you very much, and hope you enjoy. Hi, we are Team Norfolk, and our topic is reducing maternal mortality by tackling mental health. Our team members include Carl Larson, Natasha Singh Miller, Jasmine Lane, Hannah Skudlarek, Kathy Feinholm, and Tori Powell. Team Norfolk was surprised to discover that mental health is a contributing factor to a large portion of maternal mortality cases. One of the issues within mental health care is access to care, which can be attributed to financial, geographic, and social support gaps. We propose that the Commonwealth work to improve access to care for all new mothers, and especially those who may be facing these barriers. Our proposed solution is identifying those with a gap in access to care through a required questionnaire and providing home visits within 6 weeks of birth. Mental health conditions comprise 23% of maternal deaths in the United States. This includes deaths to suicides and overdose related to substance use disorder. Mental illness does not directly kill women, but it serves as an underlying factor that may result in suicide, accidental death, and death due to accidental drug intoxication or homicide. In 2020, approximately 64,000 women in Virginia were treated for mental health conditions, many of whom were within their childbearing years. As seen by these charts, mental illness was a critical factor in almost 1/3 of maternal mortality cases in Virginia. Furthermore, of those cases, the cause of death was oftentimes related to substance use. To combat mental illness and provide high-quality care, access to care is critical. Maternal mental illness is oftentimes negatively impacted by missed opportunities for treatment, missed appointments, and low social and familial support. The more a patient is seen by a provider, the more an important diagnosis or treatment can be provided. In order to do so, barriers to access to care must be removed. This map shows all mental health and substance abuse treatment facilities in the Commonwealth. Team Norfolk ran an analysis to show that census blocks and population are outside of a 30-minute drive time of a facility. As seen in this map, 495,392 people are outside of a 30-minute drive of a mental health or substance abuse facility. Additionally, there are many households that do not have a vehicle. Per our analysis, census data shows that approximately 30,000 households are outside of a 30-minute drive of a mental health or substance abuse facility. Many more are within the 30-minute drive range, but don't have easy public transportation to appointments. Team Norfolk is proposing to help reduce the risk factors associated with postpartum depression and mental illness leading to maternal mortality by having increased access to care. This would include telehealth services in conjunction with in-person home care or community group therapy sessions. We would also propose referendums to have prenatal and postpartum mental health coverage included in health insurance and Medicaid. But the question remains, how do healthcare providers identify new mothers who have difficulty with access to mental health services? For that, a questionnaire should be required for new mothers that specifically addresses access to mental health care. This questionnaire would be given 1 to 2 weeks prior to delivery and include the following questions. Have you ever sought the help of a mental health professional? How would you rate your access to mental health care during your pregnancy? Did you face challenges with transportation to healthcare during your pregnancy? Do you have access to a vehicle? How many minutes does it take for you to transport to an appointment? Are you aware of mental health services offered in your area? Are you aware of mental health telehealth services offered in your state? Would you be interested in a home visit by a mental health professional? And would you be interested in a telehealth appointment with a mental health professional? By identifying mothers who have difficulties with access to mental health care, critical gaps in care can be covered by healthcare providers, local community service boards, telehealth providers, and the Commonwealth. Here are our sources for the project, and thank you very much for your time.
Thank you again, Team 20, City of Norfolk. We're now going to move on to Team 21. It's a group of friends, and their name is Pop-Up Video. Team 21, I think you are also here. Thank you.
I love that group of friends has persisted because we all work at different employers. So that's how I described us. Great job, Team Norfolk. Congratulations to all the teams. I'm Lauren Downey. You're going to meet my team in a minute. We're really excited to share, I think, some unique insights that we haven't heard today. Looking forward to it. Thanks.
Thank you.
Hello, and thank you for joining Team 21 Pop-Up Video's 2023 Datathon presentation on unmasking maternal mortality. I'm Kelsey Faribaugh, and I'm joined here today by Lauren Downey. Our other teammates are Sam Wendler and Brennan Dye. To begin unmasking maternal mortality, we sought to better understand what maternal mortality rate, or MMR, looks like in the United States relative to the rest of the world. Based on 2020 data, the US ranks third highest in MMR, falling behind Mexico and Costa Rica. From 2018 to 2020, we see an MMR increase in the US. This increase is especially troubling when you consider that Black women in the US have 2.8 times the rate of maternal mortality of white women. Now that we've contextualized the fact that MMR is a pressing issue in the United States overall, we took a deep dive at MMR at a state level. Virginia ranks 13th highest in the country on MMR out of 37 reporting states based on CDC data from 2018 to 2021. The CDC reports state-level data in multi-year increments, and recent data was bucketed into two overlapping segments, 2018 to 2020 and 2018 to 2021. When comparing those two data sets, we find that MMR has increased by 30% in Virginia, indicating that MMR in 2021 increased at quite a dramatic clip. With our positioning as the 13th highest in the country and MMR on the rise, we must make a commitment to the 8.6 million citizens of the Commonwealth of Virginia to do better. Before we deep dive into our analysis and statistical modeling, we want to present well-established drivers of MMR as a fact to be built upon later. The WHO and CDC recognize social determinants, chronic health conditions, and healthcare access as contributing factors to MMR. We wanted to build upon those known factors to present an additional key determinant of MMR, abortion. And right now, Virginia's maternal mortality outlook is bleak as Governor Youngkin's agenda threatens lives. Our analysis will prove that access to abortion has a strong correlation with maternal outcomes. Visually represented here on the left, you'll see state mortality rates plotted against a categorization of their policy positioning regarding abortion access. States that have a hostile political stance, as defined by the criteria on the right, have the highest MMR. Compare this against states on the very supportive side of the axis with the lowest MMR. Virginia currently sits in the middle of the pack with the leans hostile rating, as highlighted in blue. If we move towards greater policy hostility surrounding abortion, we will argue that MMR will increase. And I'll turn it over to Lauren to prove this out.
Thanks, Kelsey. So what we did is we modeled the impact of abortion restrictions and protections on maternal mortality in the United States. We considered a lot of state-level variables that are all well known to be correlated with maternal mortality. When we take a look at all of these variables together, we built a really strong predictive model that models maternal mortality based on the following most significant variables: abortion policy rating, the percent of the population that is Black, the percent of women who are uninsured, and the percent of adults with Medicaid coverage. With our best model, we found that for each 1-step increase in abortion restrictiveness, maternal mortality rate increases by 2.5. And this finding is well supported by other studies from different researchers who have reached the same conclusion about the relationship between abortion policy and maternal mortality in the US. What this means for Virginia is that if Virginia backslides from leans hostile to more significant restrictions, our model predicts that maternal mortality will increase. Changing abortion policies to very hostile levels could raise maternal mortality rate by 17%. Now, I will note that this relationship represents a correlation, and it's too soon to evaluate causality based on legislation that was passed in other states in 2022. However, based on our findings, I believe that it's going to be informative and disheartening to see the impact of those more restrictive policies on maternal mortality in those states. On the other hand, we predict that strengthening abortion access could save lives. Changing abortion policies to supportive levels could reduce maternal mortality rate by 25%. And increasing abortion access has additional positive outcomes. It's been proven to reduce domestic violence, increase labor force participation, especially for Black women, expand educational achievement, and bolster lifetime earnings for women. So we conclude that any strategy to reduce maternal mortality must include protective measures for safe and accessible abortion. Our recommendations are that at a minimum, we need to prevent any additional abortion restrictions. Next, even better, we could also address the drivers of maternal mortality that we mentioned that are well known and proven by the WHO and CDC. And then our best recommendation is to also ease abortion restrictions in the Commonwealth. Now, we have all dedicated a week to developing solutions to reduce maternal mortality in the Commonwealth. Now I'll ask you to do one more thing. Please contact your legislators and tell them to protect the health of pregnant people by supporting abortion access in Virginia. Thank you.
All right, we have 2 more presentations, but we are after lunch, and so I know everyone is sagging a bit. So it's not, if you're new to Datathon, how many people was this your first Datathon? First Datathon, great. So it won't be redundant. Everyone stand up at your desks or your chairs. All right. Scratch, if you want to. I saw some eyes closing after lunch, so I thought we'd have you step. Okay. If you could grab your table or the chair with your left hand, and you're going to rotate your right leg clockwise. So for those who don't know, that would be this way. So grab your chair with your left hand and go ahead and rotate your right leg clockwise. What you people were videoing now. All right. As you're doing that, you feel good? All right. Now switch and do your left leg. Counterclockwise or clockwise, as you do it. For those Simon says there. All right. Now, a question for you. What is stronger, your leg or your finger? Finger. Finger. Great. For the non-obvious answer. Good. But many people think your leg is stronger. Good. Many people think your finger is stronger. All right, good. So we're going to take your left hand. We're going to rotate your right leg clockwise again. Everyone rotating their right leg clockwise. Pretty strong leg you got there. You're going to keep doing that. You're going to draw a 6 in the air with your right hand. No, just keep your right leg rotating clockwise. And then draw the base. Come on, guys. You got a big leg. Anybody have it? Anyone? Some people are using their left hand. I'm not going to judge you on that, but your right hand. Clockwise, draw a 6, keep your leg. Yes, no? everybody have a seat? Okay, so why would I like to have you do that other than to get some like pleasure of watching you all try to draw and that? What is important about that demonstration? You're excellent, wow. Any thoughts? What is important about why I had you rotate your right leg and draw a 6 to your right finger? Thoughts? Those who have not been data before. No one. Connected. You're connected. Good. Dexterity.
Wherever you focus your thoughts on is what's gonna.
Focus on things and they, right? You focus on this and something else changed weight and you're focused. Yeah, very good. What else? Sorry?
Coordination.
Coordination? Yes, none of us are coordinated. We fully aligned. You're gonna boost you up today. You're coordinated. Good luck. Good luck. Yeah. Okay, it's hard to focus on 2 things at one time as well. Good. Right. Sometimes opposite things collide and have to do different things. They don't always work together. Very good. I think the other thing I like to say is think of your right leg as government at work. So your right leg is the way we've always done things. We get stuck in a car. Things that happen in the state for many, many years, things at your work, whether it's VCU, George Mason, whether it's, things are stuck in the way people have always done things. And it's very hard to change that, right? People are stuck in their ways. But along comes one small motion and throws the entire cause off balance. And personally, that's what I think you all are doing today. So we're in a cog in the state of Virginia and around the country of here's how things work, here's how things have always been done. And what you all are doing is introducing something different, a different thought, a different idea, a different way of thinking about things that could have the impact of changing the way we do things. Even though the right leg is much stronger and larger, even though it's done that way for many years, one small change can change a lot of lives. So I want to thank you all for A, humoring me and doing a little calisthenics, B, staying up and getting some blood flowing after lunch, but also being part of a small change that I hope will make a bigger impact for all the time. So thank you all very much. All right. We're going to move on to a couple more thank yous. Wait, are we on time? Oh, we're good. All right. A couple more thank yous. We've already thanked our sponsors, but if you are a sponsor, I know a lot of them are outside right now, but if you are a sponsor in the room, if you could stand up as well. You're part of a sponsoring team. We truly could not do this without the sponsors in the room. Also for the SMEs, if you are a SME, some of those same people will still rise. If you're a SME in the room, if you could stand up as well. We had 2 SME sessions on Monday and Wednesday this week. We broke out into rooms. Some of you were there, some of you didn't need to be there, but it's a huge thank you to the SMEs who have been in this with us the entire time, providing guidance, providing suggestions, not solutions for the judges, but providing ideas and suggestions to the teams. To our sponsors again, GCOM, Tyler, Microsoft, Vertica, and Dataversity. We couldn't put this on without our sponsors as well, so thank you all as well. And then finally, if you're a participant in this room, go ahead and stand up again. Give yourselves a hand. And if you look outside, and sadly we have windows, so if you look outside, there are many things you all could be doing today. It's raining and pouring out. It's not a very good day at all. But as soon as you walk out, it'll be sunny. But I just want to say thank you all again for taking the time to be part of the 9th year of the Virginia Datathon. Just some amazing presentations so far. We have 2 more presentations. As a reminder, people's choice, you'll get 2 votes each. What? So vote often, just kidding. But each of you will get 2 votes. So please vote. You'll actually be selecting 2 people's choice awardees per person. And we'll have a people's choice award as well. We'll get to our last 2 presentations. Judges will go into another room to deliberate. We will take a little break. You'll do your people's choice voting. We'll come back in for awards and we'll actually get you out a little early on a Friday afternoon so you can start your weekend or continue doing work or take phone calls after this is done as well. So far, so good. Any questions? All right, why don't we get on to our next presentation? Our next group, George Mason University, team number 22, Data Angels. Is there anyone online from Data Angels?
Yes, good afternoon. There's a few of us online. We're attending from either school or work or wherever our obligations are. Again, we're from George Mason University. We're comprised of myself, Eric Torres, Gwendolyn Kennedy, Haley Kroll, and Amrisha Duivedi. And we hope you enjoy our presentation. Research is on maternal mortality and mental health. Next slide, please, Haley. We'd like to first set the scene of maternal care in Virginia. The March of Dimes has created a term, a maternal care desert. What a maternal care desert is it's a geographical area that lacks appropriate prenatal labor and delivery and postpartum care. Without the proper care, there's a higher risk of developing complications that could lead to mortality. This disproportionately affects low-income and minority populations. So the deeper the color on the map, it's more considered a maternal care desert. This, out of the 95 counties, this affects 35 counties in the state of Virginia. Next slide, please. So I thought it'd be best to start out with, screening for depression as far as mental health care goes for maternal mortality. This data comes from the Department of Medical Assistance Services. It said that there was a checkbox for yes or no. It didn't clarify if it was the patient or if it was a clinician that was doing the checkboxing. But as you can see, the blue columns are the false, which means they were not screened, and the orange columns were true that they were screened. So you can see it's disproportionately during pregnancy and after pregnancy of women not being screened. Northern Virginia did a great job with 92% of their patients screened, and Central Virginia and Southwest Virginia combined to make 7% of their patients screened for depression. And Haley will take over from here.
Thank you. So according to the CDC, mental health conditions were the leading underlying cause of maternal deaths between 2017 and 2019. So looking at the data on the left, you can see that mental illness was in the top 10 critical factors for maternal mortality. And looking at the graph on the right, at the toxicology report, mental illness medication was the most common medication found at the time of death. Mental illness medications were followed by recreational drugs, which is also something to consider is substance abuse, which can have associations with mental illness. According to the NHI, 43% people being treated for painkillers, substance use have a diagnosis or symptoms of mental illness. And then among pregnancy-related deaths, more than half occurred between a week to 1 year after pregnancy. As you can see from the graph on the left, mothers with mental illness that were treated before, during, and after pregnancy have full lines at the top of the graph. However, as you look down, the care during and after pregnancy seems to fall off the wagon. More than half of the mothers did not receive treatment after pregnancy. And from the data, we have found that 87% of deaths of mothers with mental illness were preventable. In the graph to the right, the prenatal care index shows that 27% of prenatal care is less than adequate, but the CDC recommends increased screening for postpartum depression and anxiety. So from our analysis, we are looking to increase follow-up and prevent lack of treatment. And then this is just a quick comparison of the maternal deserts that Eric showed versus severe depression rates. And just comparing the graphs, you can see some similar regions that have high severity in mental illness, but also do not have access to maternal care.
So with that access to maternal care, we can take into account how women are funding their perinatal care. Socioeconomic status is related to mental illness. People who have a low socioeconomic status are 2 to 3 more times likely to suffer from mental illness. 30% of women who have completed up through a high school education are also diagnosed with mental illness, which is a higher percent than women who have completed college or further education. So looking at this graph here, if we look through perinatal payment methods, women who were on government Medicare, Medicaid methods, there were a higher number of women across the state of Virginia who used that to pay for their perinatal care compared to women who were using insurance or women who were self-pay. Next slide, please. And then from there, we can look at how women who were suffering from mental illness were broken down by their method of payment. So women who were using government assistance there were higher numbers of women who were using government assistance who were also diagnosed with mental health disorders. We have drug use disorder, depressive disorder, which is different from depression, also tobacco use, which is classified under an addiction umbrella, and then anxiety disorder. So as we move forward in developing a solution looking at the number of patients that are on government care, completely outranking the other women who are using other methods of payment for their perinatal care. We need to ensure that government assistance programs have that mental health screening capability for pregnant women and women in that time zone after giving birth.
Hello guys, since we are discussing about the maternal infant health care, mental health care is one of the most important factors to work upon. While talking about women, access is something we must focus upon. Improve quality for maternity care and women living in the maternity care deserts. To get care on individuals who can marginalize for all their pregnancy needs. And anxiety and depression may occur in expectant and new moms, usually in the 7th and the 8th month. So we must have hospitals should take track of registered women and provide a free facility, and also should arrange a medical team which can provide support to women who need it and are comfortable around those medical teams. And also we must have teams which are preferable and are having access to the utilities required by the patients. And in concern of the women who are taking drugs, we must educate them that there are natural treatments that they can take, and after recovering from those, they must go for the pregnancy. And also we can take assistance of the government for arrangement of the utilities which are at higher cost, but we can provide them to the patients at the lower cost or for free. Thank you.
All right, giving the judges a few more seconds to tabulate. Thank you again for the People's Choice Award. That was again Team 22 from George Mason, the Data Angels. All right, another pop quiz. There's going to be a pop quiz today. And I've done this in a previous Datathon, but you're third or fourth of this Datathon, just don't answer. May 6th, 1954. None of you in this room are alive. I know. Why is that a special date? May 6th, 1954. Can anyone tell me why that is a special date? A hint. It is something I do very, very, very little of. Believe that we don't. That's false. When Datathon started 10 years ago, I had a full head of hair. Not because of Datathon. May 6, 1954, a record was broken. Sorry? Computer time. No, good. It has to do with human beings. Was that again? 4-minute mile. 4-minute mile. Anyone know the story of Roger Bannister? Oh, yeah. I know that. There you go. So Roger Bannister ran less than a 4-minute mile on May 6, 1954. Alex, already taking time telling us about May 6, 1954 and Roger Bannister. And it's something I obviously do very little of over here. So, for years it was written that the human body cannot run less than a 4-minute mile. Impossible. Can't do it. There were journals of medicine written about the human body is not constructed in a way that would ever get below a 4-minute mile, won't happen, etc. Roger Bannister did it May 6, 1954. Do I think there was something transformational about Roger Bannister? Do I think there was something about that date that changed the human body? Absolutely not. But what I can tell you is after Roger Bannister broke that record was broken multiple times after that. It didn't take, again, another 10 or 15 years to do that, but somehow between May 6, 1954. Okay, we're good. Look at that. That whole time. I just can't see because my eyes are horrible. So Roger Bannister didn't change. The human body didn't change on May 6, 1954. But what happened was Roger Bannister broke a barrier. And then once humans and people saw that barrier was no longer there, others followed suit very quickly. How do I apply to this? Because right now, each of you are breaking a barrier into a solution that we have not thought about. And my hope for this event is that while we may be the first to talk about some of these ideas, we won't be the last to talk about these ideas. And some of these ideas will actually open the way for other ideas that will come flowing that have not come to date yet. So I'm not related to Roger Bannister, but each of you are in terms of breaking a barrier and moving forward and moving the needle in Virginia about something that's been a problem for years. Now with one change, again, whether it's your finger moving the sixth or running and breaking a barrier at a 4-minute mile, we'll actually usher in new ideas and move forward in a much faster pace than we have been able to in Virginia. So a huge thank you to you all for that. All right, we're going now to our next and final presentation. Judges, good? Our last presentation of the day is from VCU School of Business, Team 24, the Eagles, and they are online. Eagles, you want to introduce yourself?
Hey, this is Manpreet here. Yeah, I and my teammate Jasmeet couldn't join in person. So I hope you like our presentation. Good morning, everyone. I am Manpreet Kaur and my teammate Jasmeet Singh represent Team Eagles. Today, we would like to share our recommendation on how to tackle the rising maternal mortality challenge. USA ranks #1 in GDP, which says a lot about the creation of economic wealth and prosperity for everyone. However, once we compare it on maternal mortality rate with other developed nations, it ranks #1 in that as well. The metric that speaks about the source of all the human horsepower of all the humans who actually create that GDP, we see a stark contrast. And knowing that we spend the highest on healthcare, what baffled us is that 4 out of 5 of these maternal deaths are preventable. And the leading cause of maternal death is maternal mortality rate is mental health. Just like other economic measures, considerable racial and ethnic disparities exist in this metric as well. Maternal mortality rate amongst Black communities is more than double the average. Documentary Aftershock speaks to that. When a mother dies, the loss to the family is unfathomable. However, how many of us truly understand the economic loss to the nation as well? We are creating, those mothers are creating those kids who will be the future leaders of this nation. DOLA program, the state certified program, is a step in the right direction. Now, how do we expand it further? How do we are suggesting a 2-step solution to this. Strengthen this and then expand it further. Expand it further and then monitor it. And how do we do it? My friend is going to add detail to that.
Thanks, Manpreet. So like she said, the program is a great step. What we want to do is make this make a new platform, which is a digital social connect between keeping the mother in the center. We bring in the mental health resources, the doulas, the mental health counselors, and community-based organizations like local churches, non-profit organizations, and bring them all together into this platform so that it'll have features in terms of ability to find a partner based on geographic and demographic tagging. A mother can look for other mothers who are in that same stage, and they can talk, they can understand and empathize with them. We can set up alerts in terms of frequent check-ins on a daily, weekly basis. How's the mother doing? They can provide things that will help us early monitoring. They can talk about local events happening in their communities, a doula visiting or a mental health seminar happening. And one thing which we have learned from our experience as well, the time after the birth is very critical, and it's all about the baby care, getting baby products. So if we can give some, we can take that time away from the mother and help her invest in herself, and instead give her like coupons on diapers, things like that, which are really essential. That'll motivate the mother to spend time on herself using this platform. On the monitoring part, what we see is we need to get better in terms of effectiveness of the DOLA programs today. So we need to enhance our data collection. From what we have seen from the Datathon, also some of the data sets are still in nascent stage. So how can we overlay the coverage of Medicaid to DOLA availability to maternal mortality rate? What is the effect of DOLA engagement? And on the other side, the new app which we are proposing to build, how many women enroll there? What are the different stages they are in? How many local organizations sign up? Can we create clusters of different women and see the effectiveness of these social digital engagement? Here, what we see, we try to create a website, but here is a kind of a prototype of the app. So women can select the role, what stage they are in, what is the journey they are on. They can try to find local events over there, what's happening. Or they can connect with somebody based on certain filters like demographic. Where do you want to meet, at a local park or a church? Who are the women who are there? What age they are in right now? A 20-year-old mother versus a 40-year-old first mother. So we could really enhance this and build it as a platform. And like Manpreet said earlier, 4 out of 5 pregnancy-related deaths are preventable. So this could be a small step, but I think it could help to move the needle as well. So let's all come together and build this. Thank you.
Thank you.
Thank you, Eagles from the VCU School of Business. All right, we have come to the end of presentations. We are going to now move into judging deliberation. So in the next couple of minutes, the judges will actually exit and go into the room where the breakfast was, and we'll have Jesse walk you over there if you need help with that. While the judges deliberate, we're going to take about a 15-minute break. You'll see on your screen before you get up the People's Choice. So I think Mike is putting up People's Choice any minute now. So you will have about 15 minutes to vote for the People's Choice Award. Again, you're going to vote for 2, and there'll be 1 People's Choice winner. We will reconvene. I'd say we'll come back in about, let's say, 20 minutes, give the judges some time. So let's say 1:25, and if I say 1:25, that means we'll start at 1:30, which is totally fine. But if you want to be back by 1:30, we'll go ahead and do the award presentations at 1:30. So please be on the lookout here in the next couple of minutes for the QR code for the People's Choice. And please be back here for 1:30 to do our awards presentation. Any questions? Thank you all again. There's a QR.
There it is. That's gonna make it lost without your help.
I have a rope for you from. Hey, Paul. It says voting is closed. Can you tell Mike that is a?
No, mine works.
Oh, now it's open.
I think you just.
Yeah, it should be open.
Yeah, yes. That's exactly correct.
Yeah, mine's saying not open either. It's open now. You
Thank you,
sure?
Mike.
Yes, until 1. I'm gonna try it again. Mine says not open yet.
You get to vote, Paul?
People's choice.
Paul must be, Mike's locked you out. Mike has said, listen, from this phone, don't take any votes.
I'm wondering if it's because I voted in the test one.
Close the browser and.
You've already voted, huh?
Yeah.
You remember which one was that? Ah, there are many high school kids.
There was Deep Run was the first one.
Was the first presentation by Data Dragon.
Tucker was the one where they were in the school.
Tucker was the one of the motion when they were, that was Tucker by school. Oh, yeah, no. We're gonna start in 30 seconds. If y'all want to grab anything, final items, and we'll go ahead and get started.
Alex, you're gonna start with
That's it. That's it. Hmm? Mistakes happen. All right, welcome back. 2 more hours and we'll have you home, I promise. No? All right. Well, first of all, again, want to thank every one of you all for taking time today and being part of a significant challenge around the Commonwealth and around the country. It's you all's presentations that actually will move the needle for the Commonwealth. I know we've talked about this as well in previous datathons. This is not just a datathon to check the box, but some of the solutions you see today will actually move into fruition. Some of the solutions, ideas, et cetera, will be moving into either pilot or test here in the next little bit. So please keep an eye out for that as well. So please know your work is not just we presented and it goes on a shelf, but these ideas will be taken by the administration, by those in the data space, and will actually be moving forward as well. So on behalf of GCOM, we've been the title sponsor. I will not take much time to say this, but I just want to say thank you again to everybody. GCOM's chief mission is to create healthier, safer, and more prosperous communities. And we do that every single day with partners like yourselves and around the Commonwealth and around the country. I'm super proud of all the work we've done at GCOM to partner in this organization, to partner with some of the data analytics work that is happening across Virginia. We're also engaged in Virginia State Police, higher education, WIC. I mean, the numerous use cases that we are coming to market with has been just truly humbling to me to see not just the impact of one thing, but how then we connect to the ecosystem around Virginia, and we have an impact that actually ripples across the Commonwealth. So on behalf of GCOM, I cannot say thank you enough. I'm not going to go on about GCOM. Y'all are here to hear your prizes. I just want to say on behalf of GCOM, thank you all. Thanks to the other sponsors as well. And thanks to ODGA and the Library of Virginia, who have just been amazing hosts. Let's give it a round of applause to ODGA. All right, so we're gonna do one more calisthenic. I'm joking. We're not gonna get up and do anything else, I promise. All right, so we're gonna start with a $25 gift card. This was a request out of the virtual. So everyone who tagged 2023 VA Datathon is in this bucket. I am going to pick one blindly. If they're not all like that, that's a great picture. That's gonna be that's a keeper right there. I was looking for my holiday picture for next year. Now I have it. Perfect. And it is Sean Murphy. Is Sean Murphy here? Oh. Yeah. Are you ready? So Sean, you'll be getting this mailed to you. But again, thank you very much. This is a $25 gift card on behalf of the Virginia Datathon. And thank you for tagging Virginia Datathon. Thank you. Thank you. Thank you. Oh, yeah, here you go. Please. You can frame that. Amazing. All right. We are now to the People's Choice Award. So you, the people, voted. The judges are just as important, but you, the people, voted. And we're going to do this in almost real time. There's some music in the background now. Okay, so the Virginia Datathon 2023 People's Choice Award goes to
Exponential Rangers.
Exponential Rangers.
Are they with us?
No, I don't believe they are here.
Are they with us online?
They may have gone to class. Oh, hey.
I'm hearing so.
Oh my God, thank you.
Excellent.
Thank you. Thank you. Okay. God, there she goes. All right, now we are going to start with third place. First of all, a huge thank you to our judges once again. Dr. Barbara Burkett, Kay Linkengauger, and Logan Fink. Thank you both all for your time today. This would not be the same without you all. You all had a lot to do, a lot to process, and I know it was a busy day of capturing everything about these amazing presentations. And I don't envy your position at all because it was very challenging to even try to put these in order. So thank you again to the judges. Our third place winner and $250 gift card goes to team number 11 from VCU, Decision Dogs. Is Dr. Treppe still here? No, she. Okay, I know she wanted to get pictures with Ken. Okay, gotcha. Congratulations to VCU Decision Dog. I don't need to be the first one. Okay, great. Congratulations, y'all get a gift card in there. Thank you. Oh. Our second place winners and winners of the second place Governor's Annual Datathon Commonwealth Trophy. Just kidding. Anyway, goes to, you've seen them already, Team 13 from J.R. Tucker High School, Exponential Rangers. Back on? Is she back on?
Where is she again?
Is she there?
Are you there?
No, dropped off. I've already wanted people choice. Yeah, I'm out. No, yes?
There she is.
You again.
Just kidding, not straight away, nothing. Finally, our first place winners. Winners of the Governor's Cup. $750 goes to. They are here in the room. Which makes everyone in the room like, whoa, all right. Oh, I'm sorry. Hello? They're all waiting. The first place for Datathon 2023 goes to William Mary Alger Griffins. There's Josh right there. Is someone, Josh, you there? Oh, Josh. Thanks, Josh. There you go. Okay. Congratulations. Congratulations. Oh, there he is.
Hi, everyone.
Let's give him another round of applause.
Oh, he's gone. He said you only get one with him.
So we'll add your names. Again, a huge round of applause for everybody today.
So really quick, can we also give a round of applause to our moderator and MC, Alex? We got, thank you, Alex, for everything. Anytime we ask Alex for help, she's always there. So
thank you.
Just on behalf of Ken and myself, thank you so much,
Thank you. My
Alex.
pleasure.
Really
Thank you.
appreciate it. Thank you.
Good partnership. Thank you. Appreciate it, sir.
Thank you.
Thank you as always. Appreciate it. All right, a few more thank yous. And if those who know me have been here before, I'm going to thank a lot of people because a lot of people made this day possible. So we've already talked about Mike Ezepek and Paul Kozlowski. Mike and Paul, could you please stand up for a second?
Yeah.
Mike and Paul from the library. You all made Mike's job a lot easier this year. Mike did not have to cut off people at 6 minutes. So I thank you again. But Mike, truly thank you for everything from the t-shirts, the awesome t-shirts you all are wearing, to the food, to the technology and everything between. Paul, for all your leadership here at the library and in Datathons for years and years. I can't thank you both enough. And this is months of work. So I know that sounds like, oh, people came together and this all happened. This team has been working for months and months to get this up and running. And every year, even though it's done it before, it's something different with new challenges, and everyone has just come together as an amazing team. So Mike and Paul, thank you again for everything. Where are Jesse and Chris? And Chris, where's Chris as well? Where's us? Yeah. Oh, and Shredder. Yep. If you're from Team ODGA, please stand up as well. Jesse, Shredder, Chris. A huge thank you. Jesse is all things comms 101 and beyond. Jesse kept us sane, grounded, and everything between, whether it's texting, phone calls, follow-ups. Jesse's been just phenomenal. Chris, thank you as well for all of your leadership, connecting the dots for the entire organization, helping prepare countless items. Shraddha, thank you for all the data prep and all the work to get the data to a space it could be. Team ODGA, again, has been a small but growing and mighty team, and it's just been delivering for the Commonwealth. I think it's amazing if you think about what is happening in the Commonwealth today with the Commonwealth Data Trust and all the things that are happening. As Secretary McDermott mentioned, I think Ken has multiple bosses around this Commonwealth. And this, again, not small, but mighty team of individuals is delivering each and every day. So kudos and congrats to the Team ODGA as well. Dr. Treadway is not here, but again, to the library and ODGA in general, again, this has been an amazing partnership, 9 years in the making, and a huge thank you to the Library of Virginia for hosting as always, and to ODGA for all the leadership as well. Finally, to the judges, as I mentioned before, Barbara Burkett, Katie Linkenauger, and Logan Fink. Again, a lot of work y'all did today to consolidate a whole bunch of information. Thank you all for your input, your time, your energy. And thank you on behalf of the teams that won for, I'm just kidding, but thank you on behalf of all the teams. Someone dropped off Girl Scout cookies, by the way. So there's some Girl Scout cookies, which I thought were gonna, they're on the table. Look at that. Perfect. Okay, good. Finally, our sponsors, GCOM, Tyler, Microsoft, Vertica, or Dataversity. If y'all are in the room, could y'all stand up as well, please? We talked about the ecosystem that makes Virginia work, and there are a lot of individuals in this room today that make this ecosystem work in partnership, and cannot thank them enough for their public-private partnerships and their sponsorship today. I think I have our SMEs. If you're a SME as well, thank you to the SMEs. You all have done an amazing job of just being there for the teams, being a sounding board, being part of the SME sessions on Monday and Wednesday. It was great to see people in different rooms. You had some people bouncing between rooms, so kudos to those who took advantage of multiple SMEs. I think we had a few people that actually went to almost every SME room. So thank you to the SMEs as well for all of their work and efforts. I think that is it as well. I'm going to do a quick round robin. Jesse, anything that I didn't cover that I should cover? Awesome, good. I always check with Jesse. Paul or Mike, anything I covered, anything?
Just thanking you.
Yes, thank you. The LVA staff as well, who's already here. Here's my final ask. It's hard to draw a line between work and life. A lot of you are here today, not drawing that line between work and life or work and family. I ask that when you leave here to close your laptop if you can, and to spend some time with you, your loved ones, or your family, and to put all of this behind you and to kind of separate and take some time over the weekend to recharge yourselves, recharge your families, and spend some time outside of work, focusing on what's also important as well. So on behalf of everyone here at Virginia Datathon 2023, I just want to thank you all for your participation. Congratulations again to our winners. And we look forward to seeing you all back here for Datathon 2024.
Yeah.
Have a great weekend.